Good morning. Good morning, everyone. Hi. I'm Karen Scott, President of the Foundation for Opioid Response Efforts, and it is such a thrill to see all of you here with us today and to welcome you to our symposium on accelerating change to address the opioid crisis. We're excited about the program that we have planned for you today. I do also want to welcome our online audience. We do have guests joining us remotely as well. And before we get into our program, we do want to take a moment and pause to acknowledge the land that we are on. So the Foundation for Opioid Response Efforts acknowledges that we are currently in the ancestral homelands of the Nechoktank and Piscataway people, as well as the diverse and vibrant Native communities who make their home here today. We honor the past, present, and future contributions of the Nechoktank and Piscataway people. We also believe in the importance of raising awareness of the exclusion and erasure of Indigenous nations and are committed to continuing our learning on this important history. Thank you. And we're going to begin our program today with me welcoming the chair of the FORE Board of Directors and specialist and leader in addiction medicine, Dr. Andrea Barthwell.
Good morning. Thank you. Thank you for responding. I know that I'm not alone, and that's very important for us, particularly in working in this area. I'm Andrea Barthwell, and I am the chair of the board of the Foundation for the Opioid Response Efforts FORE. It is the first, and it is a national foundation to focus exclusively on the opioid crisis. And over the past 5 years, we believe that we have navigated a course of impactful grant making. The three-phase opioid epidemic has tragically proven that the market for substances of misuse is responsive to demand, is extremely nimble, and is increasingly more poisonous and lethal. A balanced national strategy requires that we explore, implement, and integrate innovative solutions to prevent, intervene on, provide harm reduction services to extend life, provide treatment for, and recovery support services back in the community for those who endeavor to recover. From the start, we committed to several core principles which continue to guide our plans for the future. And we're very much focused on the future today as we celebrate 5 years of our being and plan the next decade. We said that we would cast a wide net for ideas, prioritize holistic efforts that address health and social needs, and do stuff to advance equity and social justice. Beyond who we reach with what we teach, we decided we wanted to be recognized for being transparent in our grant making. And we wanted to fund ideas and actions that foster collaboration among grantees in a broader context of community. We endeavored to identify, validate, and accelerate the broader adoption of initiatives, policies, and activities that are creative, always with the patient at the center, evidence-based, collaborative, and community embedded. Beyond our grants, those of you who are here today are quite responsible for a lot of that. Our publications and tools and webinars draw on and push out what our grantees are learning. We've reached over 6,900 people through our webinars and have had over 3,600 media mentions about our work. Right now, we welcome you, our grantees, our distinguished guests and presenters, and our board members whom you'll meet today as they have been pressed into service on each of our panels. As we come to discover the gains that we have made to date and conceive our next steps, we will be extremely attentive listeners today to your ideas. and what you found. To introduce this session, I'd like to invite Karen Scott, Dr. Scott, to the podium. Dr. Scott joined FORE together with me at its inception as our president. She is a Harvard-educated and a Johns Hopkins-trained physician with over 20 years' experience in healthcare policy, health services research, quality improvement, and public health. Her career has focused on redesigning of care to promote health equality, health quality, and patient safety at the macro level. She comes to us with the requisite experience to transform a woefully inadequate healthcare system through philanthropy. Prior to FORE, she held senior positions at the Commonwealth Fund. She was on the board of Grant Makers in Health, and most recently, she was the chief medical officer in the Office of the Assistant Secretary for Health in the Obama administration. Help me welcome Karen to the podium.
Thank you so much, Andrea. A lot. Thank you. So as Andrea said, we're here today to have all of our grantees in one place, to have special guests join us, and this is part of marking our 5th anniversary. As many of you know, the foundation was launched in the fall of 2018 when Andrea and I joined, and we made our first grant announcements on access to treatment in March of 2020. This morning, as some of you know, we announced our 99th and 100th grants. And as you can see, as you can see, as a national foundation, we have paid great attention to building a network of grantees and work that spans the country and reaches into a broad diversity of communities. You will hear from many of our grantees throughout the day, but I wanted to take just a few minutes to focus a little bit on how we've gone about the work that we do. Our grant-making programs to date have focused in these 5 main areas on improving access to treatment for vulnerable populations, responding to the COVID-19 pandemic through supporting recovery services, and evaluating temporary regulatory changes to make care more accessible. Innovation, our innovation challenge has focused on tackling some of the most intractable problems, such as finding new ways to address stigma, as well as generating timely and actionable data. This morning at our national press conference briefing, we really focused on our family and community-based prevention program for children and families at high risk, and added more work in that area. And we also earlier this year provided grants to support 22 community-based organizations to be able to build their infrastructure to work locally in their communities. As I noted, our newest grantees announced this morning our Sesame workshop, and their project will focus on working on providing the materials and the content for children, for young children through their parental addiction initiative. We also announced our grant with the American Academy of Pediatrics, and AAP will work to develop an extensive amount of training and communication activities to really make sure that pediatricians are up to speed and up to date on what the environment is like that adolescents are facing right now, particularly in a high-risk environment of a lot of the fentanyl in the schools and in communities. With all of our grants, though, regardless of the topic of the work, there are a few principles that we've really sought to stick with and work and base all of our work around. First, we have worked to be broad and inclusive in our exploration of the issues and in identifying where the foundation can have an impact. We've used our advisory meetings, our grantee progress calls, and indeed the RFPs themselves to continually learn and add to our thinking. These help shape the discussions we have with our board, with our advisory councils, as well as with staff, and that eventually leads to the programs that we develop. We've read over 2,500 proposals since the fall of 2019, learning a lot about what the gaps are and what the needs are across the country. We apply that to our own work, as well as share that information with other funders, both public and private. This learning, we think, has really helped us to inform a holistic, comprehensive approach that we endeavor to take, recognizing that no one solution, no silver bullet is going to be the single fix to such a complex problem. We've spent a lot of time, as soon as the grants have gotten, from the moment the grants have gotten up and running, on thinking about how we can promote what's working. First and foremost, we, as Andrea said, want to make sure that we have a patient-centered, person-centered approach to the work that we're prioritizing, and that we engage people with lived experience in meaningful ways. And we've built up a communication capacity, which has included press releases on new work, on our grants, on milestones. It's included expanding 4 publications. Those are our issue briefs, reports, our grantee spotlights, and as Andrea mentioned, 23 webinars that we've conducted since March of 2020. Additionally, we've been fortunate to have multiple opportunities to serve as a resource to journalists as well as to policymakers as they look at the opportunities that they have to tell the stories and respond to opportunities to address the overdose crisis. We also spend a lot of time thinking about how we create the networks of our grantees and communities of practice. Our grantees are incredibly dedicated, talented people, and we think they've appreciated the opportunity to share, to learn, to create new partnerships. And part of the role that we can play as a foundation is to help to facilitate that. And we also focus on breaking down the silos that have isolated substance use disorder work and isolated people with substance use disorder and opioid use disorder. So we work to help connect our grantees and the network of our grantees with those in other fields, including policymakers, in a concerted effort to accelerate systemic change. Many of the projects that we support are creating and adding to our knowledge base, building the evidence for what works in the real world. And already this work has resulted in at least 40 journal publications by our grantees, and we know there's many more in the works. And our partnerships with the Bipartisan Policy Center and with the National Academy for State Health Policy have supported their ability to make sure that work on opioid use disorder and overdoses is something they can continue to focus on and make sure that it continues to receive a high level of attention at both the state, the federal and state policy levels. Finally, in terms of responding to the field, earlier this year, we awarded 22 capacity building grants to community-based organizations. And I would say this was a different kind of RFP for us, a little bit different process, but it directly reflected what we had learned from our first 4 RFPs and from speaking with a range of organizations. And that was that smaller organizations, particularly in smaller communities, needed something different. They were not going to be able to respond to some of the ways we did our first RFPs. Our community-driven responses program enables smaller CBOs to have resources for staffing, for technical assistance, for consultants, and allows them to build the needed infrastructure to do the good work that they're doing in their community. Before we move on to the focus of today and the program, I do want to pause for a moment and thank the 2 groups that really make all of this work possible and make my job amazing. And that's the board of the FORE, as well as the staff. And I'd like to first ask board members, and we have 6 of our board members are with us today. I would love to ask you to stand for a moment and be thanked for your support. You met, I think Richard is upstairs. You met Dr. Barthwell, Lori Schechter is here, Letitia Waldron, Pete Sloan, Dr. Schottenfeld is was on a conference call, but he is here. He's in the building. And did I miss somebody? And David here? And David Minetta in the background. Thank you all so much. The ability to have a board that's been willing to be flexible and nimble and do off-cycle grant meetings once in a while so that we can get the grants moving and the work moving, particularly over the last 4 years, has made it possible to be able to say all the things that we're saying today and to have the map and all of you in the room. So really I feel very fortunate to have all of your support and commitment to the work we're trying to do. Next, I want to take a moment and thank the amazing, incredibly hardworking FORE staff. There's not very many of us, but it might seem like a lot more of us at times. And so I'm hoping they can all step into the room. I know they might still be checking people in. And if they can also, well, they're standing because they don't get to sit down. So Dr. Ken Chatzky is our program director. Brian Bird, our senior program officer. Sarah Villafuerte, our program associate. Young Wang, our program assistant. And Sarah and Young joined us last November. Shabani Gambier is our chief operating officer, put all of these together. And Kat Hamilton, our operations associate. I think I got everybody. So really could not certainly do any of this or any of this possible without them, and the commitment that they have to just making sure that everything we do is done with the best quality and with really the best outcome in mind. This is just wonderful to work with. So thank you. All right, so moving forward, why we're here today. Today's meeting, we really see as part of helping us think about what the next 5 years should look like and how we do that work together. We look forward to a discussion today around that vision, using much of the work that we've funded in the first 5 years to help punctuate that discussion and drive what the opportunities, what we've learned so far, and how that leads us into the future. We also really look forward to hearing from you on how we spread what we see is working, and what our grantees are learning in different parts of the country. How do we now start to bring that together so that it's not isolated, wonderful work, but really starts to contribute to the whole? So we will look forward to your contributions throughout the day. Just briefly on our program for today, the program's really built around 3 panel discussions. Each will be moderated by a member of the FORE board. First, a panel on access to treatment, and then this afternoon, panels on community-driven responses, as well as on engaging people with lived experiences. We are very pleased to welcome and have special guest speakers with us today as well. Before lunch, Dr. Yngvild Olsen, who is director of the Center for Substance Abuse Treatment at SAMHSA, and is with us, will be speaking. Just after lunch, Dr. Rebecca Haffagee, who's the principal assistant secretary in the Office of Planning and Evaluation at HHS, is with us, as will be Captain Chris Jones, now director of the Center for Substance Abuse Prevention at SAMHSA. Also this afternoon, one of our Scientific Advisory Council members, Courtney Lavelle, is here and will join our panel on engaging people with lived experience. So that's a little bit about what we have planned. I know in your folders, there's more detail about the agenda as well as bios for all of the speakers today. And at this time, I'm really pleased to ask board member Pete Sloan to come up and take over for our first panel. Thank you.
Thank you.
Thank you, and good morning, everybody. It is palpable. This room is just filled with passion and with hope. I applaud you, and I want to thank you on behalf of the entire board for your diligence, your innovation, endless innovation, and joining us in the core of what is our mission, and that is a vision to eliminate the scourge of substance and opioid use disorder in our lifetimes. I want to invite our panelists to join this morning. Brad Stein, Kate Hawk, Jackie Engelbrechten, and by Zoom, Hansel Tukes is joining us. If the panelists could join me up here on the stage, that'd be terrific. Coming out from behind the curtains and rappelling down from the rafters. Excellent. Do we have Hansel with us by video? Excellent, excellent. So I'm going to get us started up here, but the way we're going to proceed, I'm going to ask each of our panelists to tell a little bit about the work that they've done under their FORE grant. Some are ongoing. Others have closed out at least the first phase of their project work, and there are learnings and data insights that we hope they will share with us, because this is all about leveraging our shared experience and learnings. And then what we'd like to do is some Q&A. We'll have an opportunity for the audience to ask questions. I have some of my own, and let's try to mix it up a little bit and make this the robust, really fulsome learning experience that we all hope that it will be. Let me first start with Dr. Bradley Stein, who is with the RAND Corporation. And the project that RAND undertook with us, one of several, was to investigate changes in buprenorphine prescribing during the COVID-19 pandemic, and how these changes may have affected access to care and treatment outcomes among underserved populations, including Medicare beneficiaries and those in rural populations. They endeavored to explore how the observed changes in prescribing relate to different state policies as well, Medicaid and beyond. Their analysis informs decisions about whether to continue some of the COVID-era policies intended to preserve access to treatment, and what is the current status of some of those policies, which are worth hanging on to, expanding, and where we have evolved beyond them, hopefully. And Brad has a number of insights that I hope he will share with us today around whether buprenorphine prescribing actually held steady, as was the case from 2019 to 2020. And hopefully you have some more recent insight about the numbers of people that are entering and leaving treatment, which may have been lower than expected during that period, but with some of the tools and access points that policies during the public health emergency allowed, was the temporary relaxation of some of those rules and enhancements in Medicaid coverage policy. They helped some patients stay in treatment, but preliminarily, at least some of your findings were that it didn't facilitate access for new patients, and hoping to hear that we have started to close that gap. So Dr. Stein, if you can share with us a little bit about your project work.
Thank you very much. Really excited to be here this morning. It's great to actually be in a room with people doing so much important work here. I see lots of friends and lots of people who's doing wonderful things that I've respected for a long time. And I very much look forward to hearing from our panelists in just a very couple of days. I look forward to hearing the progress everyone's been making. To get us going, with Pete said, I'd like to share a little bit about what we've been learning in our FORE-supported work to better understand changes to buprenorphine prescribing during and in the context of the COVID pandemic. There we go. All right. So why is this important? Well, as I think many of you know, most studies suggest that during the pandemic, at least the number of buprenorphine prescriptions seemed to stay relatively stable. But that left us with several questions that we wanted to examine a little bit more closely. And first is, what might these top-line numbers obscure important underlying patterns sort of under the hood? Were there important differences in access to utilization of buprenorphine among different populations? And second, as Kate alluded to, during the pandemic, decision makers implemented a range of different policies that could support buprenorphine treatment. And were we able to identify associations between states implementing some of these policies and some of the buprenorphine treatment patterns we were observing? So briefly, and I know most of you aren't interested in methods too much, but let me explain. To examine these questions, we used 2019 and 2020 IQVIA data, which is pharmacy claims data that captures about 92% of prescriptions dispensed from retail pharmacies across the nation. And what we did is we created treatment episodes. So we could see the number of individuals beginning treatment, the number of people who were ending treatment, and the number of active treatment episodes, because over a two-year period, many people were in treatment for longer than that. So we wanted to make sure we were able to capture them also. We used the National Safety Council state actions to address the pandemic to identify several policies that might influence buprenorphine use. One, and I'm sure many of you are familiar with, is the ability to initiate buprenorphine treatment without an in-person visit. Another state policy we thought was relevant was banning prior authorizations for substance use disorder treatment overall. And third is we picked up 3 policies implemented by states that could support reimbursement for telehealth. One was the ability to reimburse for behavioral health via telehealth. And there were 2 other policies that sort of established payment parity. So if you provided telehealth, you got the same payment as you did for in-person visits, one for commercially insured populations and one for Medicaid enrollees. Analytically, essentially what we did is we compared what happened in 2020 post the public health emergency declaration in March compared to what would have been expected in terms of 2019. So what did we learn? Well, overall, the total number of active buprenorphine episodes stayed relatively constant. In fact, it actually increased a little bit more in 2020 than what we would have expected from 2019. But we identified several important shifts in some of the characteristics of those episodes that I think give us all sort of pause for thought going forward. First, we found that there was a substantial increase in number of episodes that were paid for primarily by Medicaid, with a corresponding significant decrease in the number of episodes that people were paying for out-of-pocket, self-pay. We also saw substantial increases in the number of episodes where the primary prescriber was a nurse practitioner or physician assistant, and a relative decrease, actually, in the number of episodes where the primary prescriber was a PCP. And this is something that we had not expected. Now, for those of us who are concerned about equity, the next one gives us a little bit of pause. The counties with the greatest percentage increase in number of buprenorphine episodes in 2020 compared to 2019 were those counties who had the greatest percentage of white residents. Other things that certainly made us think is in terms of counties with the fewest fatal overdoses were in 2018 were the counties that had the greatest increases in episodes during 2020 compared to 2019. And also counties with the lowest broadband penetration also had the most increases. And as we're considering telehealth, I think this is background that may be important to think about. Now, that's overall. But when we started to break it down and looked at new episodes, we actually saw a significant decrease in 2020 from what we would have expected in 2019. More so, we really didn't see any association between these new episodes and many of the state policies we looked at. So there's no association between the number of episodes in 2020 and being able to initiate buprenorphine episodes without an in-person visit, nor in banning telehealth. And when we looked at sort of telehealth reimbursement policies, we actually found a greater decrease in new episodes in states that were implementing all 3 of those payment policies compared to states that were implementing 1 or 0. Now, for those of you who can do simple math, if the overall number didn't change and the number of new episodes beginning went down, not surprisingly, We saw that the number of episodes ending also decreased pretty substantially. And in fact, if you looked at individuals who were in treatment on March 13th in 2020 and compared it to sort of the prior year, which is when the public health sort of crisis was declared, individuals in 2020 were actually in treatment for approximately 10 days longer than they had been in 2019. And here too, you know, the impact of policies was modest at best, and again, wasn't in the direction that we necessarily would have expected. We saw that in states that passed all 3 telehealth policies, that there are actually shorter treatment episodes, which is not necessarily what we would have expected. And also states that allowed buprenorphine initiation via telehealth also were associated with somewhat shorter episodes. So, you know, where does that leave us? And unfortunately, I don't have answers to all of your questions, but I think this is starting to shed light on some of the things that are important for us to know about. First of all, we talk about, you know, outpatient went down, buprenorphine treatment stayed stable during the pandemic. Isn't that great? Well, maybe, maybe not. Certainly, given the increased need and what we know about the crisis, I'm not sure staying stable is certainly what we were looking for. And even more so, these changes in sort of people starting treatment and people ending treatment give us pause that maybe the story isn't that things really stayed the same. Maybe that there are some really important shifts that were going on that just looking at the top line numbers aren't telling us much about. Now, there was not much of an association with the policies we examined. And in some cases, the association was sort of in directions opposite from what we would have expected. Now, let me be really clear. We're only able to look at associations with 2 years of data. We can't sort of do the type of causal inference and say these are things that were caused by these policies. But at the same time, it certainly gives us pause as we're thinking about how do we think about these policies sort of going forward. And because a lot of these policies are under discussion right now. Telehealth is one example, right? I personally am a great fan of telehealth. I don't think it's going to go away. And looking at the data that some of you in this room are producing, it really seems that people who are receiving telehealth, there are a lot of advantages for that. But I think when we look at telehealth from a population perspective, at least our initial findings suggest that maybe the issues may be a little bit more nuanced. When we start to consider the effects of policies and how is there shifts in what patients and prescribers are doing, there may be some countervailing factors. I also think as we think about going forward and what we learned from the pandemic, it's really important to remember that during the pandemic, there are so many other societal changes. Lack of Medicaid disenrollment, right? Oftentimes as people were stopping treatment, it may be they're rolling off of Medicaid and they no longer have insurance. That stopped for quite a while and was probably of tremendous benefit. And I think sadly, there may be a natural experiment now going on across the states as we're sort of unwinding that. I think it's something that certainly is very concerning. I think it's also important to recognize that during the pandemic, there were very important differences in sort of decreased competing demands for time for many individuals and greater flexibility in how they use that time, which very much may have influenced how they interacted with the healthcare system. And so I think as we're trying to understand and learn from our experiences over the last several years, while we can look at the policies and the other things we've been implementing, I think our work has suggested that it's equally important to understand what some of those flexibilities and other changes may have created, because maybe the magic and some of the benefits we're seeing may be derived from some of those other societal changes rather than the policies themselves. So I don't have the answers. I wish I had the answers. Maybe come back in a year from now and I'll have more answers. But hopefully, to kick us off, I've given you all something to think about. I know there are many others of you in this room who are doing this work. Maybe you'll have the answers, but at the very least, I'm looking forward to learning from you. Thank you very much.
Excellent. Thank you, Brad. Kate Hawk, Dr. Catherine Hawk, is with us today, representing a grant partnership with the American College of Emergency Physicians, who oftentimes are on the front lines and the first to observe an overdose case and to contemplate what are the warm handoffs and what's the full continuum of care that patient will need and not just be discharged from the emergency department. I was struck, I looked at the data last night out of curiosity, that fully 130 million visits through the emergency department occur in our country every year. That's a staggering number. It's a third of our country's population. So the Emergency Medicine Foundation is a not-for-profit founded by the American College of Emergency Physicians. And the intent of their project around emergency quality network initiatives is to provide intensive, tailored coaching and support to 70 emergency departments over 2 years to enhance their capacity to initiate buprenorphine and dispense naloxone to patients with opioid use disorder. EMF will also partner with the Naloxone Project to conduct an environmental scan of naloxone dispensing practices in 10 states with emergency departments, emergency doctors, and support states' capacity to increase naloxone distribution across a variety of clinical settings. Kate?
Do I need to click it? No. Thanks so much for inviting me to be here today. Oh, all right, there we go, that's me. Thanks so much for inviting me to be here today. And actually, I'm gonna take a step back because the project that we're talking about here today is actually really a second set or a second version of the initial project that was funded by the FORE-funded. And so what the project that we are working on today is through the American College of Emergency Physicians. In 2017, we launched something called the Emergency Quality Network Opioid Initiative, which the idea was to develop, engage a network of emergency departments around the country who participated in a structured national structured quality improvement project. In exchange, they got MIPS credits for participating. And the goal was really for us to be able to communicate some of the ideas around best practices for opioid prescribing and for care of patients with opioid use disorder in the emergency department using this very, very low-touch network. So this was initially launched in 2017. The first 2 waves focused on opioid prescribing, and then in 2020, with the FORE-funded, we actually were able to switch into where I think we really know the heart of the problem is, for what we see in the emergency department at least, is really enhancing care for patients with opioid use disorder. And actually, Scott Weiner is my co-lead back there. He's not up here today, but we've been doing this work together since 2017. And so in 2020, part of our project was to develop quality measures that are really focused on improving care of patients with opioid use disorder in the emergency department. And so we used our technical expertise panel to look at a set of 6 measures. They're exactly what you would expect them to be. So it's evaluation for an opioid use disorder, ability to refer patients for opioid use disorder, dispensing naloxone for people who come into the ED with the ICD-10 code of opioid overdose or opioid use disorder, dispensation of medications for opioid use disorder, specifically buprenorphine or methadone, and prescription of buprenorphine for patients who are seen in the ED after opioid overdose or with a diagnosis of opioid use disorder. And so over the course of this period, we have actually engaged more than 1,400 emergency departments across the U.S. They're primarily community EDs, rural EDs. These are the EDs who have a single medical director who's trying to do the 25 things that you need to do in order to get an ED up and running. So it's very different from the necessary clinical practice that you see in academic emergency shops, like where I practice and Scott practices, where we have lots of people to do quality improvement projects, to build opioid use disorder treatment pathways, who have time and interest in sort of championing these projects. This project is really built on figuring out how to, take what we learned from these academic emergency departments and really get it out into the community where we know people receive care. And so from 2020 to 2022, that was the initial project that was funded by FORE. And then this year, in March, we launched our next sort of phase. It's focused on a boost. And so the idea is, it was initially launched as a very low touch way for us to engage EDs, to provide information through webinars, through articles, and other sort of podcast educational activities. And this project that we're doing right now is actually allowing us to provide a little bit more intensive one-on-one sort of coaching and implementation facilitation to EDs that, we are able to identify who have, an interest and a local champion who is interested in prescribing buprenorphine and really helping to build their program and improve care for patients in their DED with opioid use disorder. I will say, overall, it is somewhat disheartening that we do know that the numbers of EDs that currently prescribe buprenorphine for patients with opioid use disorder or post-overdose is extraordinarily low. We have seen increases over the course of this work, but they're still very much in the single digits, less than 5%. And so our goal is really to help, identify these EDs where there is, a local champion or a change agent that we can meet with, that we can help provide, a number of sort of one-on-one meetings with them, with their clinicians, practitioners, and really to help figure out how to have folks build a project and build a program without reinventing the wheel. Scott and I have done work in probably, definitely more than dozens of EDs around the country to help figure out how to build these programs, how to get, how to reduce stigma, how to change expectations in the ED, how to build buy-in with your clinicians, with your nurses, pharmacists. And so a lot of this is really around how we can translate what we've seen in other EDs and really to help make it easy to change practice. Because I do really think that although many emergency physicians were not trained in how to prescribe buprenorphine or how to care for patients with opioid use disorder clinically, by and large, they do want to do the right thing for the patient. It's just that you just need to provide an environment where it's easy for them to do so. And so this entire project is really around how you can provide them with the support and the education to really help build those programs and figure out how to engage their clinicians and providing what we really know is the standard of care for patients post-overdose. And by that, it specifically means offering medication-based treatment, either methadone or buprenorphine, and providing naloxone to everyone to walk through the door who is identified as having opioid use disorder or overdose. They're willing to have it. So we just launched this portion of the grant in March, and so far we've currently engaged with 12 emergency departments who are around the country who are interested in helping build their programs. And it is really it's heartening to find these people, because I think that often people will reach out to us, but it's all sort of a one-off. And this structure provides us the ability to have a structure to meet with folks. This is what we're doing. This is the expectation. Can we come back and meet with you and your clinicians in a month? Talk about how you made progress, how you set up and identified your outpatient treatment providers, and really figure out how to sort of move things forward. And so I'm excited to see where it goes. And it's just really, really encouraging to see EDs out there that are really trying to figure out how to do a better job taking care of these patients. Because we do know that we are the ones that see them post-overdose. We are, for better or worse, a safety net of the healthcare system. And, while there are still challenges around sort of culture and stigma that I think we might talk about later, I think, by and large, these are clinicians who have seen young people die of overdose every day in their ED. And I think it's, a lot of what we do is spend our time trying to help people leverage that from despair and to really empowering them to provide the care that they why they went into medicine in the first place. I think I'm going to stop there, and then if you have other questions.
Excellent. Thank you, Kate. And on to Jackie Yngvild. So FORE, in this instance, did a grant to the Alaska Native Tribal Health Consortium. But first, a little bit of context. And as I learned more, the more I realized that we are as passionate and as knowledgeable as some of us are becoming, understanding the particular challenges on Native lands and in the far reaches, rural reaches of a state like Alaska presents innumerable additional challenges, and learning from those could have applicability with other populations as well. Let me tell you a little bit about the scope of the problem. Compared to 2015, there was a threefold increase in the number of individuals identified, diagnosed with opioid use disorder. And overdoses involving fentanyl have also increased across the state, doubling in the first half of 2020. And I suspect that Jackie will have some more recent data for us. The Alaska Native Tribal Health Consortium, which supports tribal health organizations in meeting the needs of more than 200,000 Alaska Native and American Indian people, is using funding from FORE to enhance access to medications for opioid use disorder in the state's rural and remote regions. In particular, Jackie, when you talk, some of what I've read about you and the organizations that you work with had to do with the importance of recognizing being sensitive to issues around local culture and tradition. And you said something that I thought was very prescient, and that was part of recovering from addiction is recovering your sense of identity and rebuilding connections to your community. And would love if you would talk about that, because otherwise all we've succeeded in doing is diagnosing and maybe some preliminary treatment for patients. But we also need at the same time to make sure that community-based providers are familiar with local culture and traditions so that they don't perpetuate racism and stigma and ignore the traditions that are so important to providing culturally sensitive care. So Jackie, if you can come up and talk about your project work, that'd be fabulous.
Thank you. Jackie Yngvild, Veteran Kokana Priaksintian, Ujisulan, Alaska Native Tribal Health Consortium Kahosna. My name is Jackie Yngvild. I am Otna Athabaskan. My family is from Golcana, which is in the Copper River region of Alaska, famous for our salmon. I live and work in Anchorage, though, and I work at the Alaska Native Tribal Health Consortium. I am pleased to be here to introduce you a little bit to the tribal health system and to talk about what we are specifically doing. So Alaska is a very complex state. I know many of you are probably familiar with it because of reality TV. We use a hub and spoke model in the state. The Alaska Native Tribal Health Consortium has the vision that Alaska Native people are the healthiest people in the world and can't do that alone. And so we work in partnership with the 229 tribes in the state to improve healthcare so that we can reach that vision. So on this slide here, I have a diagram of how referral patterns work in Alaska. It's unique. We do run and cooperate the largest tribal health hospital in the country, and we do that in partnership, as I mentioned, with our tribal health partners. So typically, a person would receive healthcare at a clinic in their village. These clinics are very small and are often staffed by paraprofessionals. We have dental health aides, behavioral health aides, and community health aides. So that's how the majority of people would receive care in these communities. If they need advanced care, they are referred to one of the hub communities, many of which have hospitals. However, these hub communities are still small communities and these are still small hospitals. So that if they need more advanced care, they'll go to Anchorage. This is a really big deal. And I think after leaving the state for a little bit and coming back, I really truly realized rural in Alaska is very different than rural in the rest of the country. And using the term remote is a very accurate descriptor because many of our communities are not on the road system. The only way to get there is by airplane, snowmobile or snow machine is what we call them in Alaska, or boat. So that presents a pretty difficult challenge. And most of these communities don't have, they're not connected to the road system. They don't have even like traffic lights. That was a big deal to me when I moved to Anchorage, learning how to navigate traffic. So it's a big deal for people to come from a very rural part of the state to come to Alaska for care. So what we're doing here is we have 4 different things that we really worked on with the 4-tier approach, which included education, consultation, developing a rural toolkit, and improving our data and analytics infrastructure to capture people who are experiencing challenges with opioid use and connecting them to care. Through our education, we ran an addiction medicine echo that is ending actually today. Today is our last one. And we worked with a regular group of people. There were probably about 30 people who consistently attended for the last 2 years. And in that education, we included components about cultural care. We had traditional healers participate. We had people talk about their own personal experience receiving care outside of the system. We also worked very closely with one of our our experts in the state, who is interestingly enough in a rural community that is not typical in our state, for her to work with other providers to increase their confidence to provide that kind of care. We did have a success recently. I can't claim it was the entirety of the success. One of the regions in our state recently started providing MOUD, and that was a significant part of their work, but also their providers participated in our addiction medicine echo, and they received consultation from our provider that was doing that, which is important because that region of the state has some of our highest rates. They have some of the highest stigma. A big part of it was providers in their clinic were very against providing care based on very antiquated ideas, as many of you are probably familiar. But because of that, there's a huge portion of our state that's now receiving care that they weren't able to receive before. And in particular, that region has a lot of people who are coming for commercial fishing. And so part of that consultation, working with our other provider, who also happens to live in a fishing community, was talking about different solutions for how can we serve these fishermen when they're gone for long. And, one of the easier answers is that, they would put them on Sublocade, long-acting Sublocade. But it's still a big challenge. We have many people who work in that kind of capacity. Our toolkit, we worked in partnership with our state. They developed their own toolkit. We had one that was more rural and tribal specific. And they also wanted to spend a little bit of time talking about our public health outcomes, our population health outcomes. We've been investing heavily in the Alaska Tribal Health System and data and analytics. And so we used some of our grant funding to pay for a dashboard to be developed to help communities identify people in their region that might be prescribed opioids or that might have an opioid use diagnosis who aren't receiving MAT, or if they are receiving MAT, if they haven't checked in a while, you can check that in the population health outcomes. Then you can get a list of people who are, who need follow-up care. And really, that's a list of people who are most at risk for overdose. So we work very close in partnership with them as well, our data and analytics team, and we've heard really great things from providers in our region. Our grant is ending, but the work is not ending. We're continuing this work, and we're also continuing our work around cultural competency as well. But that's not related to this grant. So there's a lot of work that still needs to be done. I am a storyteller. I did not bring data. We have an epidemiologist that works very closely. I call him our epidemiologist, but he's the one that does that. But we unfortunately have not seen an improvement, and we're working the best that we can to try to make as much change as possible. Thank you.
Excellent. I'd like to invite by video, I see him with us here now, Hansel Tukes, MD from University of Miami, who is a FORE grantee studying rapid implementation of peer navigator-led telemedicine for medications for OUD in response to COVID-19. And in particular, Dr. Tukes is focused on the more recent narrowing of overdose cases and mortality between Black and white communities. It has narrowed significantly, in part because of the addition of synthetic opioids in addition to other drugs. And despite the more pressing need for treatment, Black Americans have less access to treatment of buprenorphine than white Americans, and would love for Dr. Tukes to talk to us about that a little bit. For much of the last 2 decades, opioid-related overdoses among Black Americans have been obscured by media and other observers. Reporting that has emphasized the impact of the opioid crisis on largely white, rural, and suburban populations. For many of those years, overdose deaths were significant, but the per capita rate was about half of what it was for white Americans. Unfortunately, as I say, that gap is now closing, in part with the emergence of synthetics like fentanyl. Would love for Dr. Tukes to tell us about the IDEA Exchange, which is a first syringe services program in Florida, seeking to expand access to medications for OUD in other underserved communities by offering tele-MUOD services on its mobile van, staffed with peer recovery specialists, which is really a core element of the work that Dr. Tukes and his team have undertaken. And those are recovery specialists serving as ambassadors in the communities which they reflect, and with deep ties. And the mobile unit seeks to connect patients to clinicians at the IDEA brick and mortar clinic, and who can prescribe medications, lead patients through the induction process, and schedule follow-up telehealth visits. The peer recovery specialist involved in those patient interactions guides patients and lead online recovery support groups. Dr. Tukes.
Well, I'm so sorry, excuse me, that I can't be there today. It's funny, every time you say IDEA, I cringe. That was, I have to tell you a little story. So I did spearhead the effort to bring syringe services programs to Florida. And the reason that we named the bill the Infectious Disease Elimination Act is because we wanted to differentiate from all of the legislators saying, oh, the students are here for the needle bill, for the needle bill. So that was a branding strategy that worked, because now we have syringe services programs legalized statewide in Florida. But if I had to do it over again, I would not have named the first legal syringe services program in Florida with the letters DEA in them. Okay, so I will start by describing the problem to you. Next slide, please. So using data to improve implementation, when we looked at the first 700 participants in IDEA, and just to give you a little bit of background, IDEA was not implemented until World AIDS Day of 2016, and that was after a 5-year effort to have a pilot program in Miami. So it was imperative for us to do rapid implementation science-based research so that we could advocate for a statewide expansion. When we looked at the first 700 participants enrolled in IDEA, they had a mean age of 38, about 75% male. We saw significant challenges with racial and ethnic minoritized communities. Now, this made for a very, very tense exchange when I first presented our first year data to the Miami Board of County Commissioners, but they placed their faith in me to remedy what was happening in our program, which is similar to what's happened in many programs. So if you look at IDEA, in our first year, we were 52% serving, 52% of the people who inject drugs who were enrolled were white, only 7% were Black, and 36% were Hispanic. And that may sound on its face like that is in pursuit of racial equity, but if you look at the census of Miami-Dade County is 14% white, 17% Black, and 69% Hispanic. So there was a major problem in our ability to effectively engage other communities. Now, when we looked at the fixed site versus the mobile van, we saw some hope. So in the mobile van, it was 38% white versus 55% at the fixed site. The mobile van was able to engage, 18% of the people they were able to engage were from the Black community of people who inject drugs versus 5% at the fixed site. The mobile van had more women, more Black folks, more people who were houseless, 62% versus 38% at the fixed site, more people who reported being unemployed, more people reporting an annual income less than $5,000, and more hepatitis C, 52% at the mobile site versus 41% at the fixed site. So what this told us in the paper to the left is that we needed to meet people where they were, the central tenet of harm reduction, both mentally and physically. But we had to overcome marginalization, minoritization, and stigma by going into the communities that we hoped to serve. Additionally, we looked in the paper on the right, the baseline prevalence and correlates of HIV and hepatitis C infection. Overall, at the IDEA Exchange, in the absence of legal harm reduction programs for decades, our hepatitis C positivity was 44%. Correlates of infection were increasing age, lower educational level, and houselessness. And we had an astounding 10% prevalence of HIV. The number one predictor of HIV infection was Black race. That was remarkable to me when we first did this analysis. The adjusted odds were 1.28 compared to non-Hispanic white individuals who used our program. So significant risk in communities that have just been historically marginalized nationwide. we had a lot of work to do. So we won the FORE grant in 2020, and this was an opportune time. This was the intersection of the COVID lockdown, the need to get services to individuals that we had been serving over the prior years. Our students were no longer in school. They wanted to serve the community. They were in their apartments, despondent. So we applied for this grant so that we could get buprenorphine to minoritized communities, given the disparities for access in the literature. So to improve equitable reach, we hired a peer with lived experience who looked like the community we sought to serve. We invested in a mobile unit. We actually have our second very beautiful mobile unit now, and we targeted historically Black communities in Miami. Now, Miami still has all the vestiges of segregation. They prevail. And so we had to hire staff that had more ties to the historically underserved Black community in Miami. And this was a top priority for me as a Black physician who was leading the first legal harm reduction program. You have Dr. Eddie Suarez in the audience today, who also leads IDEA Miami, a Cuban American. We wanted to make sure that we were engaging communities of need in Miami-Dade County. Next slide, please. So when we decided to make this action to improve equitable reach, on the left, you see fixed site enrollment at IDEA. And you can see that it remained relatively stable. We did have some gains in serving the Hispanic community. What is remarkable is the slide on the right. When you look at mobile enrollment, you see the direct impacts of the investment by FORE to increase our equitable reach. We had an immediate surge in the number of Black people who inject drugs that we served, followed by gains in the Hispanic community. And these gains persist to today. So demographically, IDEA now serves a predominantly minoritized community as our demographics better reflect those of Miami-Dade County. There is still work to do. Future challenges will include retention on buprenorphine. So we leveraged our mobile unit to bring, and telehealth to bring low barrier access to buprenorphine to all of Miami-Dade County. And in a paper first authored by Dr. Suarez, who's there with you today, in our pilot of 109 people, we served a more diverse community, so 15% Black, 36% Hispanic. Our 3-month retention was 59%. But one thing that was significantly associated with lower adjusted odds of retention on buprenorphine at 3 months was stimulant use at baseline. So we have significant challenges related to the ubiquitous stimulant use in the community that we serve at IDEA Miami. Of course, in line with recent literature that has come out, we had 8 times the adjusted odds of retention with escalated buprenorphine doses to 24 and 36 milligrams. And we had 7.5 times the adjusted odds of retention when we leveraged telehealth or our teleharm reduction intervention to bring high quality, low barrier medical services to people where they are. So we are optimizing ways to increase our equitable reach at IDEA Miami. We have a lot more work to do, but we are committed to the task despite the politics of our I heard you call Alaska complex. Well, I'm coming to you live from Florida, so we have increased complexity here. And I would just like to say I thank FORE for the critical funding and support during lockdown year. Thank you.
Since you've got the virtual microphone, Dr. Tukes, I'm going to go in reverse order on some questions and invite the audience to think about questions you'd like to pose to our panelists, our grantees here today. So I love that you are talking about meeting people where they are and helping to train your peer recovery coaches who look like the communities they purport to serve. And in particular, what I'd love you to comment a little bit more on are the retaining and training of peer recovery coaches in the Black community to serve in these roles on the mobile van and guiding patients as the project contemplates. What did you discover about peer review coaching that surprised you? And what are some of your takeaways or learnings that you think have broader applicability that you'd love to share with the audience?
Yeah, thank you for that question. There are significant challenges to hiring and not hiring peers, though you have to get through the University of Miami background checks, but really supporting peers in their roles. We've had challenges with adequately supporting our peers, particularly when we hire people who were previous participants in the idea exchange. We don't use a formalized peer recovery specialist certification at the state level. We hadn't historically in the past. We looked at people who had been in recovery for a year, and if they were on their medications for opioid use disorder and they seemed eager to work at the idea exchange, we hired them. I mean, having somebody who previously used our program, somebody who was very well known in the streets for a variety of reasons that I shall not discuss here, having him as the main person to facilitate our outreach to the community and what is possible with medications for opioid use disorder. Because as he used to joke, they see me and an underhanded compliment as if I could do it, anybody can do it, was critical. I'm reflecting upon my first PACHA meeting was last week, the Presidential Advisory Council for HIV/AIDS. And we were in West Virginia, appropriately, because that is where the largest HIV outbreak amongst people who inject drugs is, and that's where the highest per capita overdose rate is. And when we're talking about having people who look like the community there to serve, I noticed this firsthand. Like, even though I'm an expert in bringing low barrier, high quality HIV care to people who inject drugs, surprise, I did not look like the community in West Virginia. And I felt that they were not as receptive to my suggestions as they might have been. So I think that as we all, in the face of everything that's going on in this country, seek to pursue racial equity, I think that we have to really look at the importance of hiring people with ties to historically minoritized communities and who look like historically minoritized communities in order to adequately to attempt to adequately overcome all of the vestiges of segregation and current discrimination in order to best serve them.
Thanks so much, Dr. Tukes. And you've noted elsewhere that hiring people with lived experience has been the best thing that's ever happened to your program. So congratulations on that. Jackie, if I may turn back to you, you made clear that Alaska poses some very unique challenges attributable largely to geography. What I'd like you to talk about are two things, if you would. One, that oftentimes seeing a patient upon an overdose or at risk and initiating treatment happens in a more populated area, be it Anchorage or elsewhere, but then they go off to the vast rural areas of your great state, back to their timber and fishing and other jobs, or back into their tribal community. And how do you overcome that care gap? One, and then two, if you could talk a little bit more about the importance of doing that through one's native cultural lens.
Sure.
You're on, I think.
Okay.
Yep.
So one of the things I neglected to mention was the most important thing. One of our biggest goals is to keep care closer to home. And as mentioned, a big part of that is because people are in community, they're with their people, they can do their traditional activities, they can eat their traditional food. And that is a big part of why we did this. Alaska has a long history of removing people from their communities, whether it be children, sending them to boarding schools, or even just sending people out of state because there wasn't services available. So our biggest goal is to work with our tribal health partners to have them start these programs so that they continue care. Unfortunately, a lot of people right now still have to travel to Anchorage or some of the hub communities to receive their care. One of the benefits is that, we do have long-lasting treatments that can help. It reduces the amount of time people need to come. But one of our biggest challenges is that there's still not enough communities that have that. And there's still not enough treatment options in the state. So people are still leaving. And unfortunately, when people leave, they very often don't come back. So one of the benefits of being in their region is that as I mentioned, they're connected to their people and their traditions. You know, they can come to Anchorage and they can find people who are from their region and they can get that connection, but honestly, it's still very hard. You know, people will be in the hospital or they'll be in their different programs, but they won't be able to eat, you know, moose, for instance. Moose is actually one of the easier ones. You know, they can't get whales in Anchorage very easily. And there's just something to be said about having your traditional foods and being with people who love you unconditionally. And they're just not able to get that if they have to leave their communities. So our biggest goal by far for just about every work we do is how can we keep people where they're happiest and where they're healthiest.
Excellent. Well said. Kate, you noted in your remarks that 10% of emergency docs prescribe buprenorphine. And it goes to a broader question around the elimination of the X waiver by the Congress last year. And at least based on my limited readings on the subject, it has not resulted necessarily in a higher utilization of buprenorphine. And we're still trying to ascertain the reasons for that. I suspect stigma is somewhere near the top of the list. So I'd love you to comment on how we can expand those numbers at the ED.
Okay, yeah. So thank you. So I should correct you. So I don't actually think the number is 10%. The number is actually, particularly when we look in rural and community emergency departments, the number is actually, when we actually look at ED visits for opioid overdose, the number is less than 10% of with prescription. As part of our, I didn't really dig into all of the data we're collecting. We do capability assessments, and so it is around 10% of the EDs that did say, you know, that they did have an X waiver clinician or they were capable of it. But we all know that there's a difference between being capable of something and actually doing it, which is, you know, honestly a large part of what our project is really about, is trying to help figure out how to push people and push that clinical practice to it being standard of care. I think you're absolutely right that stigma is a huge part of it. I mean, I think part of it is also, you know, it's also just fear. You know, people didn't learn how to do this as part of their training. It's a new medication. You know, a lot of the regulation around it, I think, was scary and intimidating. It just seemed unnecessarily confusing. Although the elimination of the X waiver is by no means the thing that is really going to flip the switch on emergency clinicians. It does make it definitely easier, but it has still been this sort of mysterious special medication that you had to have all this special education and training. And so I think it will sort of forever be, or maybe not forever, but at least in the next few years, it is sort of marred as this mysterious thing that, you know, was not, people actually got to say that's not part of my practice, which is really, I think in retrospect, really kind of a shocking. So as far as, you know, how we can actually help embrace or promote clinician change around initiating buprenorphine and distributing naloxone. I mean, I will say, I mean, so ASAP, the American College of Emergency Physicians, has really been a wonderful partner in trying to help move physician practice. We certainly know that most of my hat is actually doing implementation studies around ED-initiated buprenorphine, NIDA, and through one of the clinical trials I did, this was probably 5 years ago, I met with a community physician in New Hampshire who said, "What, you know, I don't care that you're from Yale. I don't care about the study in JAMA. You know, what I want to see is something from ASAP that says this is something that we should." At the time, that was not something that existed, but ASAP has been really wonderful in helping sort of promote that. And now, I guess in last summer, in June of 2021, we actually released consensus guidelines on the treatment of opioid use disorder from the emergency department. This includes buprenorphine. And so, you know, I do think, you know, that is this combination of trying to figure out how to push, you know, data and clinical trials around, you know, improving. I guess I didn't mention, 2015, there was a study that showed that people who were initiated on buprenorphine in our emergency department were more than twice as likely to be in treatment in 30 days than those who just received a referral. So those studies are very compelling to some people. That is not the thing that is actually going to speak or change clinical practice. So, you know, I think part of it is changing expectations and changing norms. and as I mentioned before, it's really just, making it easy and having people, giving them the tools to make it. I think it's trying to sort of where we are. Unfortunately, it still feels very, very slow with this incredible rate of overdose deaths that we continue to see. Although we're still move the ball down the line. I don't, whatever your analogy is.
Down the court, down the field, whatever you like. Yeah. Excellent. So before I pose a question to Brad, there is a microphone in the center aisle here. Those that have questions, feel free to step up to the microphone, and we'll take as many of them as we possibly can. Brad, for you, I'd like you to comment on two things, somewhat related. The first, based on two of the takeaways I had from your earlier remarks. One, that there was, over the study period, an increase in the number of episodes paid by Medicaid, but there were less for patients who would pay out of pocket. Understand the correlation there, but in a post-public health emergency world where those Medicaid flexibilities have largely gone away or been curtailed, for those that are not Medicaid expansion states, what is the data, what is your sense of the data tell you about patients in those states in particular?
All right, two fairly complicated questions. Let me take on the first one because I think I've got a fairly easy answer for the first one.
And I'm sorry to interject. The second part of the same question was,
all right.
What does the data tell us about disparities in access to treatment?
Okay. Disparities in access to treatment are pretty clear, at least historically. Minoritized populations, particularly Black individuals and individuals living in communities with more minoritized individuals, have historically had less access to buprenorphine. And I think any number of studies have shown that. And it gets a little bit more complicated, but let me start there. Second question, let me go back to the first one. In terms of Medicaid paying more, I think this is pretty clear in that you didn't have individuals rolling off of Medicaid, right? You had both expanded Medicaid, you had people losing commercial insurance and rolling onto Medicaid and not rolling off. And so I think pretty clearly what you had is more individuals who hadn't continued to have insurance and so had episodes being able to be reimbursed by Medicaid. So I think those two things are fairly straightforward. I think the ongoing evolution of COVID, I'm not quite sure I'm at the post-COVID world yet, although I'd like to be there, is that I'm tremendously concerned about Medicaid unwinding because we know that these are very vulnerable populations. They're losing insurance. I don't think we have data yet, but I certainly suspect that that's something that's going to matter. I do think over time, we have seen greater coverage for buprenorphine and other medication treatment for opioid use disorder, and so I'm hoping to some extent that counteracts it. All of that said, I think the insurance coverage is necessary but not sufficient. I think even if we were to maintain Medicaid coverage and even losing it, there are any number of other things we need to be thinking about how to make sure in the world going forward that we sustain and increase coverage to medication treatment. And so the example I'd like to use, and I'm happy to expand this, is I'm going to say something somewhat provocative for those of you in the audience who know me. This probably is not a surprise, but I would argue that historically much of our efforts have been removing what we see as perceived barriers to medication treatment. That is where our mindset has been. And I think some of that may be driven by people like us, for this is something really important and we see barriers, and if we take them away, isn't everyone like us and wants to be providing more treatment? And sadly, I don't think that's the world. And if you listen to my colleagues all talk today, it wasn't removing barriers, but it was really thinking about interventions, many of which can be supported by policy, that are much more proactive in terms of education, in terms of consultation, in terms of outreach, in terms of providing
beyond just a prescriber, a waivered prescriber to prescribe buprenorphine, but peer navigators. All of these things are somewhat more proactive, and I think comparatively, there has been far less attention to those particular dimensions and more towards removing barriers that I would suggest for so many people out there weren't really truly barriers. So that is the argument I would make. I also think in terms of the health equity, this is something that's particularly concerning because I do think that there are examples of policies that may raise all boats, and so they improve access to medication treatment overall, but may actually widen disparities. And an example that I think gave me pause when I saw the data is I think there's some data supporting that this has happened, that's something that happened with Medicaid expansion. And at Medicaid expansion, clearly more individuals with Medicaid in expansion states received buprenorphine, right? That's pretty clear. But as you look at the data, most of those benefits in terms of expanded dispensing of buprenorphine accrued in those communities with fewer residents of color. And so while it lifted all boats, it may have actually widened disparities. And so I think we need to be very, very intentional in thinking about policies specifically that may be able to address some of these gaps.
Excellent. Thank you, Brad. Now we have questions from the audience, quite a few of them I see. We've got about 5 minutes, which means I'm going to ask your indulgence to keep your questions as brief as possible.
I'll try to be as brief as possible. I actually had a question for Kate, but I can't resist first. With Brad, you've raised such provocative questions, but cutting to the chase, the sort of lack of federal guidance as to what adequacy is in the Medicaid programs is, when you try to think about the levers that could actually drive these changes, because when we look at the states that are non-expansion states, some that have very big populations, Florida, Texas, Mississippi, et cetera. And when you look at this, as we've been doing as well with IQVIA data, it's extraordinary that there's something about those states that is also associated with lower rates of treatment, even within the Medicaid, the smaller Medicaid eligible population. And when you look at the proportion of buprenorphine scripts that are covered by Medicaid in Florida, Texas, Mississippi, a number of other states, and a few outside the South, but more in the South, they are in many cases less than 20% versus, let's say, 66% Vermont versus 50% in Kentucky, places like Kentucky, Massachusetts. So that's a huge issue with the role of Medicaid, which is absolutely critical. So how do we change that? Well, it's ultimately a political struggle, who makes decisions about this, but how do we change things in healthcare? And I completely agree, Brad, with your comments that you need to do more than just eliminating these barriers. And we're already learning that all the effort that we put in with the elimination of the X waiver may not have gotten us by itself where we wanted to go. So just quickly, how do we get federal direction? Because in the end, in healthcare, how do you change who gets what thing? You do it with payment, and you do it with enforceable guidelines and with measurement-driven quality assurance. So my sort of comment to Kate, I won't take the time to go into it, but it's very much along the same lines, which is ED physicians follow protocols and they follow accepted standards. So how do we change the guidance that they get from, in New Jersey, we have a very interesting thing where one of our largest health hospital systems is providing financial incentives, more payment to hospitals that have more ED-based view. So how do we use policy tools? I guess in both questions, how do we really change this with policy tools that could come from CMS, from states?
Great questions. Lots there to unpack. Brad, you want to start?
So, Steve, I just want to be clear. You want me to answer how I'm going to change the entire healthcare system in the next 30 seconds? I just want to get the expectations clear here. All right. So two observations very clearly. You know, Medicaid expansion we're paying a lot of attention to. I do think it moves the needle. I think one of the things we don't pay attention to is states that didn't expand Medicaid may have used other resources to counteract. So if you look at Medicaid expansion, clearly helped Medicaid enrollees. Several studies suggest it may not have moved the needle as much for the entire population, right? You may have had shifting of payer other than payer. I do think overall, and there's a much deeper question to this, I think you need both top down and bottom up. I think we can set guidelines. I think we can set regulations. I think we can set metrics. CMMI, there have been lots of examples of doing this that in many cases have not been as successful as many of the advocates may have hoped. I don't think we give those up, but I think at the same time, we need to look at ground up education from points of training, consultation, a lot of on the ground work. It's not as sexy, it's not as easy to do, but in the end, to sustainably, to adopt, implement, and sustain moving the needle, I think that's where you need to be, because if you set these high metrics, people meet them and then a metric changes and they shoot at that metric. I think both are there, but I don't think you can ignore the ground up.
So there are a couple of different things. I know we don't have a ton of time, but so, I mean, I do think quality measures is something that can certainly be helpful. And it's really hard to measure denominators when you think about who should be offered buprenorphine, who gets buprenorphine, who gets naloxone. Some people have home naloxone and don't want it. But I think the bare minimum, it's the existence of these things are happening in your emergency department should sort of be a bare minimum, and it's a reliable target to.
So Little Birdie in the Sky told me that there are several questions for you, Dr. Tukes, that are largely the same, and they revolve around the question of how do we best support our peer recovery coaches and your staff on the van and beyond?
That's a difficult question. Perhaps our behavioral health director, Dr. Eddie Suarez, who's in the audience, can better answer it. But you know, I think that everything that we're doing in harm reduction in Florida has been done in more progressive parts of the country for decades. And so we've sought counsel of other programs in order to better serve our peers who are on staff. It is probably the biggest success of our program to have people who previously exchanged syringes with us on our staff. But there are complex mental health needs, even once people are taking their buprenorphine and doing well. There's decades of trauma that need to be unpacked. Some strategies that we've used at IDEA are having, Dr. Suarez can say the right word, but debriefing sessions where the peers come together and they can talk about how the work is currently affecting them. Of course, we have many physicians on staff, but the physicians are no longer serving the peers who are on staff, which is challenging because, you know, we've taken care of them for a very long time, but Human Resources does not want us to continue taking care of them once they work for the university. So we are definitely still finding our way. I think that mental health treatment is a key part of that, particularly related to working in the same space where one previously received services. I don't know if Dr. Suarez has anything to add to that.
He said you nailed it, buddy, if you didn't hear that. On that note, I'm going to ask everybody's indulgence because we've got our very special guest, Dr. Olsen, who is about to join us here on stage. The panel will be here. You all know where to find Dr. Tukes as well. Please come forward with your questions during the lunch hour or during any of the breaks. And I'm sure our panelists would be delighted to engage. But thank you to our panelists. Please join me in giving them a round of applause. Consistent with DC Common Law, I've just declared squatters' rights here at the podium, and I'm not leaving for a week. No, you'll be rid of me here very shortly. I have the distinct honor and privilege of introducing Dr. Yngvild Olsen. She is the director of the Center for Substance Abuse Treatment at SAMHSA. It is important to note that both CARA and the Support Act, the latter being reauthorized hopefully this year by a highly productive and functional Congress, it really reaffirmed and expanded the critical role that SAMHSA plays, not just in grant making, but really leveraging a lot of the best practices that we're hearing about here and beyond. I am particularly pleased that Dr. Olsen is a 20-year plus practicing internal medicine doc and a treatment specialist, where she has been an office provided opioid treatment provider and a certified opioid treatment program director. And I think those are really critical perspectives to bring to our discussion. Dr. Olsen serves as the director, as I said, for CSAT. She's got a long history of working within the addiction treatment field to expand access to care and enhance quality. Dr. Olsen has held numerous senior volunteer leadership positions in the field of addiction medicine. These have included Vice President of the American Society of Addiction Medicine, President of the Maryland Association for the Treatment of Opioid Dependence, the President of the Maryland DC Society for Addiction Medicine. She's also served on numerous boards in the state of Maryland. After graduating from Harvard Medical School, Dr. Olsen completed residency training in internal medicine and served as primary care chief resident at Boston Medical Center. She completed a fellowship in general internal medicine at Johns Hopkins, during which time she received a master's in public health degree from the Johns Hopkins Bloomberg School of Public Health. She has practiced internal medicine for more than 20 years. She has written and lectured extensively on opioid use disorder and its treatments, the stigma of addiction, the integration of behavioral health and medical care, and clinical and policy solutions to the opioid epidemic. She draws inspiration from the opportunity to provide care for people with substance abuse disorders as an addiction medicine specialist and a general internist. Thank you, Dr. Olsen, for being with us today.
Oh, yes, the clicker. So I have some slides, but I'm going to kind of talk through them quickly because I know that also there are, I think I'm standing between you and lunch, and I just also am so inspired by the experiences, the work that we just heard about. You know, I think as someone who has been in this field and really now trying to kind of help continue to push forward all the evidence base that we have, all the practices that we just heard about, to also make sure that everyone has an opportunity to experience the benefits of these interventions, given the crisis that we face in this country. That really, this is just incredibly inspiring. And I think, you know, what you all are doing kind of at FORE grantees, really the ideas, the implementation piece, as well as the evidence that you're generating from all that is so incredibly helpful for us at SAMHSA and at CSAT and the work that we do, because we all really need to be doing this together. And that top-down, bottom-up approach, I love that. That is absolutely, I think, kind of one of the things that that maybe you'll see in some of the slides that I have as well. So I'm not going to go through this, but just to, again, you know, highlight that we are facing an incredible overdose and substance use disorder crisis that is becoming increasingly complex, increasingly dangerous, and that while we have these fabulous evidence-based interventions, that only small percentages of people are getting them. And in fact, from the National Survey on Drug Use and Health, what we also see is that there are many people, 95% of the people who actually meet the diagnostic criteria for substance use disorder actually even think that they need treatment. So that proactive, like, we have to be out there. We have to get out into communities to actually really help engage people in ways that we just haven't necessarily been. And that's where I think so much of the work that you all are doing really comes in. Because we also know that there's hope. There are millions of Americans in recovery who have that experience and are also willing to share that, you know, as peers, as we just kind of heard about.
But I think that, just taking a larger, just kind of a step back and looking at the larger system, part of the challenge I also think is that we have just these uncoordinated systems, right? It comes as no surprise to this group, but really the systems that people who have a substance use disorder find themselves in, particularly when they have an opioid use disorder, it goes from, general health care, emergency departments, primary care clinics, to specialty treatment centers where not, people can find some treatment, some recovery. We can talk more about that, but also the criminal justice system, right? Public health, we talk about harm reduction, housing and social services, and all of these things, there are some overlaps, and we are obviously kind of trying to connect dots as much as possible. But people still have a very hard time navigating through these systems wherever they are at different stages of recovery, and their families. And families really trying to help people seek care, seek services that are helpful to them. That gets hard when you're having to multitask and prioritize different. There's an appointment time over here and the same appointment time over here. How do you choose between those? So part of what we do at SAMHSA, and particularly at CSAT, is thinking through how do we actually then connect more dots. That I love puzzles, and so connecting puzzles and puzzle pieces and dots is a huge thing for me. And so really thinking about how are we expanding access to and quality of effective care in much more coordinated, integrated systems that includes general health care, includes specialty treatment, it includes public health, housing and social services, and for the current period of time, also includes public safety. And how do we actually make those connections to save and improve the lives of people with substance use disorders and related conditions, and one that is grounded in recovery and equity for so many of the reasons we've just heard about. And incorporates those social determinants of health. So we're really taking a whole person approach to make sure that individuals are getting that chance at whatever stage of recovery they might be, wherever they are, such that there are no wrong doors to services, and they really get to help drive and define kind of what that recovery looks like for them. And so at CSAT, we do that within the framework of SAMHSA's strategic priorities. This is a slide from SAMHSA's recently released strategic plan that really looks at kind of preventing substance use and overdose, and really, again, kind of that full spectrum of prevention, harm reduction, treatment, and recovery across the lifespan. So it's also then inclusive of adolescents and children and families, youth, all the way up to older adults as well, and making sure that we have a well-trained, comprehensive behavioral health workforce that can also really meet the challenges. And we know that we have significant issues in that area as well. And that people don't necessarily come in just with behavioral health conditions or physical health conditions, right? So really making sure that we're kind of looking at that integration as well. And we do that under the guiding frameworks of the HHS overdose prevention strategy that I think you're going to hear a little bit more about. That again, for the first time, really recognize that harm reduction is a core pillar in this whole continuum, and that proactive approach is something that we really need to be just paying much more attention to and meeting people where they are. We also do that under the framework of the National Drug Control Strategy that has over 80 action items, 70 of which touch SAMHSA in some way. So we get a lot of our marching orders from the Office of National Drug Control Policy, but in a very holistic, I think, and very complementary way. So we really, I think the alignment with all of these policies and strategies is incredibly exciting to me. So I just want to highlight a couple of the opportunities that have already been mentioned that really I do think kind of present new opportunities and some new challenges for us as we talked about. That the elimination of the X waiver that was done through the Section 1262 of the Consolidated Appropriations Act, or otherwise more affectionately known as the MAD Act,
really for the first time, I remember getting my X waiver like training in 2001, kind of very, very early on. And the idea that, kind of, yes, we had to have this training and the special thing, maybe it was a good idea then. I think it is one of those where, obviously Congress and others have seen their way to saying kind of times have changed. At the end of 2022, there were 130,000 waiver practitioners across the country. The DEA estimates that there are over 1.8 million registrants, DEA registered practitioners. Not all of them are probably jumping up and saying, we know, I want to do this, but you can see just the opportunities and the potential really for just expanding access. And I totally agree that, I think that what we have learned through the last few years and now with the removal is that, this may be one of those that is going to be helpful, but it is not the thing that is going to, kind of change the world. But I do think that now being able to say, you don't need this special training is really kind of at least removing one reason for people not necessarily doing this. The other thing I wanted to highlight is, just before I leave the Med Act, so we do now on SAMHSA's website have a statement that says, we are no longer taking applications for waiver training, and we encourage all DEA registered practitioners to really prescribe buprenorphine, assuming also that their state laws allow them to do that. And so, I think kind of the other piece of what we do at the federal government is kind of set the federal policies. At the states and your work in states, I think, is also another just huge opportunity for FORE to really complement and amplify many of the things that are happening at the federal level. The one other thing I wanted to, the policy change related to Section 1263 of the Consolidated Appropriations Act, or the MATE Act. Some people have said, well, we got rid of the training requirement in math, but now there's this training requirement for substance use disorder training under MATE. What gives? Well, I think that part of this is that, as someone mentioned before, I thought when I was in medical school, we had 2 hours of training on addiction, on substance use disorders. And granted, that was many years ago, but, I just spoke with some medical students a couple weeks ago in Missouri. They also got 2 hours, and they're in their second year. So it hasn't, universally changed that much, and hasn't universally changed sufficiently enough that I think we are at a point where we, can say that every practitioner, whether it be a physician, nurse practitioner, physician assistant, social worker, kind of multidisciplinary team, that we don't need more to really make an effort to say, no, people need to be trained in this. Because even if someone is not going to be prescribing buprenorphine or, other things, we as healthcare practitioners prescribe a lot of control medications, and understanding, what is a substance use disorder, how to make that diagnosis, how to think about treatment, what is your role as a practitioner, in that care and in that care continuum is really, really important. And so that, I think, is what kind of the MATE Act is really hoping to do. So, one of the things that we've been at SAMHSA working very closely with the DEA to implement both MAT and MATE. Part of the challenge is that the law, Section 1263, did not specify the content for that training, and there is no authority for us to mandate the content. There's some broad categories within the law, but essentially what we did with input from lots of our federal partners, external experts, associations that do a lot of the training that is alluded to and are named in the section, was we put together recommendations for curricular elements in substance use disorder training, really also wanting to highlight that not only is it about kind of the screening, diagnosis, and treatment and management with medications,
but also that it includes things like paying attention to stigma, like the trauma-informed approaches, like really understanding some of the historical and racial issues that people then, from minoritized communities come with, and how we really need to think about kind of that whole person as well. I just also want to mention that, CSAT, so the OTP regulations, that also is part of what we hold, and that opioid treatment programs, while we can talk a lot about kind of, their role, their history, et cetera, that we have seen some growth, particularly over the last few years, also including mobile medication units and non-medication units. The most recent, this is actually just from April, and we've been continuing to add more OTPs across the country. There are now over 2,000 of them spread across. Now, is that enough? I think in many communities, like Wyoming doesn't have any. So, there are many communities that really don't have access to methadone. And given that OTPs right now are the only place that really methadone can be accessed, with some exceptions, that, we are working very hard also to make sure that methadone within the regulatory framework can be as accessible as possible. And so that is the proposed revisions to Part 8 that the SAMHSA released in December, really tries to not only incorporate the medication take-home flexibilities that we saw under COVID that have proven to be safe and effective in helping people stay in care and go on with their lives in recovery. And making sure that we're also proposing to make changes to the practice environment within an OTP to really incorporate harm reduction and non-stigmatizing language and multidisciplinary teams and services that really span that harm reduction, treatment, and recovery continuum. Because having worked as an OTP medical director for 10 years, where we provided hepatitis C treatment, we, did kind of primary care light services, we had a health home. Like, I know also kind of what is possible, and so that I know that this is an, OTPs aren't for everyone, but it certainly is. There's an opportunity here to really help make some changes, and we are working very hard, kind of through lots of various different actions with our federal partners, through all of our training and technical assistance resources, outreach, again, trying to also be as proactive as we can be within the limitations that we have as the federal government and at SAMHSA, and really wanting to make sure that we're working collectively with everyone to move to really save lives and improve health. And part of what also is really exciting for me also, and I think you're going to maybe even hear some more about this from my colleague Chris Jones this afternoon, but is also the fact that harm reduction pillar is so incredibly important, and the harm reduction framework that SAMHSA has put together following a 2-day summit that included a number of different people from across that continuum, and with the incredible input of a steering committee that really helped inform this harm reduction framework. This is going to, I think, drive also and inform many of the things that the SAMHSA is doing in terms of policies and practices. And in fact, we've infused harm reduction activities into I think over 15 of our grant notices of funding opportunity to really just, again, that whole integration between harm reduction, treatment, and recovery in many, many different settings as well. And one of the pieces that we've also really been working with states on is naloxone saturation and making sure that we can get naloxone to those communities at highest risk, with also the funding that we provide to states through both the State Opioid Response Grant Program, as well as the block grant programs and other discretionary grant programs. And we are continuing to do this through learning series. We had a virtual all-state learning community back in January. We had a 10-state policy academy in July.
We are working on follow-up for all of those, and states are doing some really, really, really exciting things. And so I think, again, kind of connecting dots, some of the dots that I heard already this morning, really being able to connect some of the dots of what's happening, I think is another exciting opportunity, I think, for us. But we mentioned stigma, and I do think that this is one of those areas where, we need more. We need more collaborative efforts. We need really, to work more together, put heads together to help overcome that. Because it's someone who has had patients on methadone who, have come to me and said, I got fired from my job, or I'm going to lose my kids because I take methadone and CPS is now coming to take them away. I mean, there's just so much more we have to do in this area. And I think, there is a fair body of evidence that obviously shows that stigma is a leading factor for people either not entering treatment, for practitioners not offering treatment in different clinical settings. So, and systems, and we've already heard about some of that today. But I am a firm believer that when we really can work together, we can help overcome that stigma and help those families and communities receive care and achieve well-being and thrive, because that really is SAMHSA's vision and mission, and a mission that I'm really excited to be able to be part of with everyone kind of collectively, because that's really what it's going to take. So I just wanted to end because, this, to me also, this is not just numbers, right? I mean, we're losing 110,000 people a year in 2022 and 2021, but they're people. And, when we see people who have a substance use disorder, who have an opiate use disorder as the people that they are, it is just incredibly inspiring. It's incredibly inspiring kind of, this federal government still lets me out for a few hours every Friday morning to go see some of the, and be part of the care of some people that I've been taking care of for 10 years. And, being part of that up and down and up and down and up and down is just incredibly rewarding. And so that's really what I carry with me kind of everywhere I go and every day. So thank you so much for having me here. Karen, thank you so much for the invitation. Andrea Blackwell, wherever you are, and all of you for all the work that you do and all of the work you're going to continue to do. So thank you.
Dr. Olsen, thank you so much for joining us today and for your leadership. It is, I think we are all so grateful that you are in the role that you're in and so aligned with the work that everyone here is trying to accomplish. We have reached the break in our day where we are going to take a break for lunch. And just outside the door where you have breakfast, lunch will be waiting for you. And we are going to reconvene at just about 1:40 to hear from our next guest speaker. So thank you for this great morning. Thank you, everyone.
Last night, I assume? I just want to look in a hotel. Know where I'm going to go. What? So I'm glad you told me about the hotel. It was like, no, your conference?
Hey, good. How are you?
Good. Blake Fagan, and
Oh,
I'm in Asheville, North Carolina.
oh, nice.
Yeah.
Yeah, you guys keep coming up, Mayhex, in all my conversations.
Oh.
Kate. Yes. I'm going to get in the shorter line.
Okay. Is that right? Yeah.
Engaging people
We definitely have some activity going on right now. A number of things. One of the big survey them or not. Medication, Narcan, referral. Excellent.
Yeah. Yeah.
How many? Thank you.
Hi, everyone. Hi, everyone. Great. Thank you. I'm going to ask everyone to start to come back into the main room. You can bring your plates with you. If we can all start to reconvene. Thank you. Hi, everyone. We're going to get started in just a minute. If we can get everyone back in the room. Actually, in following Dr. Haffiji, if I can also ask the panelists who are going to be on our next panel on community-driven approaches to perhaps come up and take the seats in the front of the room so you can join us on stage after Dr. Haffiji. Thank you. Great. Well, it is wonderful to see all of the networking and conversation that's been going on across lunch, and hope everyone has gotten a chance to get something to eat. We are really thrilled to be able to hear from another member of leadership on these issues at the federal level in the Department of Health and Human Services. Dr. Rebecca Haffiji is the Principal Deputy Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. Dr. Haffiji has been in that role since March of 2021. Excuse me. And before joining ASPE, she has been a policy researcher at the RAND Corporation, as well as an assistant professor of health management and policy at the University of Michigan School of Public Health. Dr. Haffajee is a lawyer as well as a health policy researcher, and she combines her work on detailed legal analysis with empirical investigations of the relationships between policy and health. Her main research interests are behavioral health, drug policy, and public health policy. Kind of couldn't have a more perfect combination of skills and interests for this meeting. So we are grateful for her leadership. She's a recipient of multiple awards, including the Academy Health Outstanding Dissertation Award, and her work has been published in the New England Journal of Medicine, Journal of American Medical Association, Annals of Internal Medicine, JAMA Psychiatry, etc. Been covered by the New York Times, the Washington Post, and NPR. Dr. Haffajee received her PhD in health policy, her JD and her MPH, all from Harvard. And prior to pursuing health policy research, she practiced healthcare law at Ropes and Gray. I'm very thrilled to welcome Rebecca to the stage, and we look forward to hearing from you. Thank you so much.
Okay, great. Hello, everybody. It's wonderful to be here, and thank you so much for the invitation, Dr. Scott and FORE. It's really a privilege. I remember, a little bit before I entered government, learning about the FORE and the work that it was doing, and being so excited that there was such an organization and philanthropic grant-making entity that was being established. And it's so exciting to see where it is at 5 years and all the wonderful work that I'm sure soon is to come. I'm Rebecca Haffajee, and thank you for the lovely introduction. I am in ASPE at the Department of Health and Human Services. And just to give you a little background, ASPE is the principal advisor to the Secretary of Health and Human Services, Secretary Becerra, on policy development in health, disability, human services, data, and science. We conduct research evaluations, both intramural and extramural, and economic analyses of policies, and we lead on special initiatives across the department and really do a lot of coordination across when things are cross-cutting across agencies. And so one such initiative that we led is the overdose prevention strategy for the department, which I will talk about momentarily. Working. So I'm going to talk about the OPS, so the overdose prevention strategy, some of our accomplishments, and then some of our future efforts and where we would like to go, particularly in the next year. So this overdose prevention strategy, we devised shortly when I came into the administration, the beginning of the administration, pulled it together and released it in October of 2021. So we're coming up upon our second anniversary now. And it really was designed to address the opioid and overdose crisis and reduce drug overdose morbidity and mortality in the nation. So prior administrations did have opioid strategies. Under Obama, it was a 3-point strategy that focused a lot on opioid prescribing and expanded use of naloxone and expansion of medication-assisted treatment therapy. Under the Trump administration and Brett Giroir, it was a 5-point strategy that focused on the betters, so better data, pain management, targeting of naloxone, research and addiction prevention, and treatment and recovery services. Both strategies did really focus a lot on opioids and a lot on prescribing, which was where a lot of where we were at in the crisis at the time. And so when we came into this administration, we really thought about what do we need to do now? And where is the crisis? What would have the most impact? We did a lot of talking about the opioid public health emergency, which I had written about before entering the administration, and that while symbolic, that was maybe not the most effective legal tool and giving us the levers to do what we wanted in the opioid crisis. And so pulled together a team of 8 agencies within HHS that work strongly on this topic. And decided to come up with a new strategy under this administration that reflected the moment and where we wanted to go. And so as you heard some from Dr. Olsen, we came up with this overdose prevention strategy. It aligns nicely with the ONDCP National Drug Control Strategy as well. And it has 4 pillars. So the first is primary prevention, harm reduction, evidence-based treatment, and recovery supports. Under each of those pillars, we have objectives as to 4 each actually, as to what we want to achieve. And when we rolled the strategy out, we had 44 key activities within HHS under those pillars as to what we were doing and what was imminently on the horizon. And we've added to that in subsequent years. And we have 4 cross-cutting principles as well. Those include equity and really making sure this is a administration priority, a secretarial priority, and something I actually work on separately on the Health Disparities Council within HHS a lot within the department, but really making sure that we're maximizing health equity for all. We are making sure that underserved populations are a focus of our work and that we're providing culturally competent care and addressing underlying social determinants of health. Data and evidence was another key issue, and my background and being an ASPE, this was incredibly important to me, that we actually are doing data-informed strategies. We are measuring our work and trying to see what progress we are made. Where we don't have the data, we're identifying those gaps and coming up with strategies to fill them. Another cross-cutting piece was the coordination, collaboration, and integration. This really was aiming to break down the barriers and silos that are typical of substance use disorder services and that separate it from other types of healthcare and other types of social services, and instead promoting integrated care and care along the continuum. And then finally, reducing stigma, which we've already heard about quite a bit, but without doing that and really leading in communication and messaging on that front, that we were not going to make a lot of progress. A couple of other innovative things about the strategy I'd like to highlight. I don't have time to get into all of the objectives and specific activities, although you'll see some of those in our accomplishments. It's really comprehensive focus across the whole continuum of a lifespan of someone, and then also the continuum of care and services that they would receive. The integration across sectors and types of care. The focus on harm reduction and recovery supports is really novel. This is not something that has been an emphasis in prior administrations and work, and you've heard some from Dr. Olsen. I think you'll hear more from Dr. Jones about the harm reduction, but we are really taking those on seriously and thinking about what we can do, also within the confines of what's legal, but also what we can take on in those regards. And then I think closing the gap between research and evidence that we're generating largely through NIH, NIDA, and CDC, and then connecting that to the services and supports that we're actually delivering in our care to beneficiaries. And then I think the final thing is the substantial investments. Our fiscal year 2022 initiatives on overdose totaled over 11 billion, and that was a 54% increase over the prior year. We proposed even more in FY23. We've been a little hampered by Congress and the continuing resolutions and budget constraints, but are maximizing everything we can do with the money that we have. And this is our website, so you can go to it, and the URL is down there if you would like to learn more about the activities and specifics. So I'd like to highlight a few things in our year 1 accomplishments. I won't even cover all of these, and these are just a few. But one, I think in prevention, really thinking about improved education and financing. So on the education piece and guidelines, we did have the 2022 CDC prescriber guidelines, which are recommendations for clinicians who are providing care for patients with pain, including those prescribing opioids. And focused on acute pain in addition to subacute pain and chronic pain, and were supplements to the 2016 guidelines. We also had CMS, our Centers for Medicare and Medicaid Services, issuing new payments for chronic pain management, and so paying physicians separately for spending the time with patients with chronic pain to create and modify treatment plans and coordinate team-based comprehensive chronic pain care plans with them, so enhanced reimbursement for that. Under harm reduction, you heard from Dr. Olsen about the saturation plans that SAMHSA is working on naloxone, and really working through the data on what those say and how to work with states to make sure naloxone is widely available. FDA also approved new naloxone products, most notably the second generation naloxone intranasal spray, and continue to innovate in that regard. On the treatments, Dr. Yngvild didn't speak to this too much, but the OTPs, I think what's notable is the methadone take-home that was initiated at the beginning of the COVID-19 pandemic, and the proposal to actually make those flexibilities permanent, because the feedback on that has been very positive, and we have not seen evidence of diversion as a result. We also had CMS finalizing a physician fee schedule that was actually quite comprehensive, had a lot in it, but most notably in this regard, increased Medicare payment rates for OTPs in order to better reflect the costs of individual therapy, and finalized changes to stabilize the payments for treatment of patients with methadone and OTPs. Also said that OTPs could bill Medicare for care that was provided through mobile units like vans. So that was another big innovation. Also on the treatment side, I would note, and there are some of our friends from HRSA in the audience, HRSA has given out billions in treatment funds, 104 million to improve treatment in rural areas, 1.6 billion in awards to improve treatment in that first year. So large amounts of money going out. And then finally, on recovery supports, I'd like to highlight SAMHSA established an Office of Recovery Services. And it's a national clearinghouse and resource for recovery services that is really trying to centralize these services and provide guidance and technical assistance as well. Within ASPE, we led an evaluation, something else that happened in the beginning of the administration, the precursor to eliminating the DATA waiver. This was our issuance of the new practice guidelines that allowed prescribers to actually prescribe buprenorphine to patients, up to 30 patients, without obtaining the waiver. This was a pandemic measure to enhance prescribing. We did an evaluation and found that similar to some of what we've heard earlier this morning, this is associated with an acceleration and a growth in the waivered clinicians. You can see that red line after the intervention was the 30E was the people who got the waiver through that mechanism. And we saw a large increase in although the trend had been going down overall in waivers before, but we saw it really augmented the number of waivered prescribers after we put that policy into place. However, we did not find that was associated with increased numbers of patients who were receiving buprenorphine, as you heard earlier, but there are nuances that we heard from Brad Stein. So, you know, I think our conclusion there was, again, that was one step and a precursor to the removal of the waiver, but it's not, as we've heard, the silver bullet, and is not going to, you know, in and of itself, increase prescribing. In year two, we're kind of taking stock of our accomplishments now. A couple of things to highlight. CDC has been doing a lot around prevention and awareness campaigns. So their prescription awareness campaign tells the stories of people whose lives have been impacted by prescription opioid misuse and overdose, and really to increase awareness around the dangers around certain opioid use, and to reinforce that help is available for those with opioid use disorder. In terms of harm reduction, many of you are aware of the over-the-counter naloxone approval from FDA that I think will make naloxone more widely available within pharmacies. The question is what impact that has on the overall market, and so we are assessing those impacts and really want to make sure that everybody who wants naloxone can get it through various mechanisms. In terms of treatment access, we have done demonstrations to increase the capacity of Medicaid providers providing substance use disorder treatment. CMS, ARC, and SAMHSA are doing 3-year demonstrations to increase that capacity and to really coordinate all of their services in this regard. HRSA, I'll note, continues to do amazing work with their rural communities opioid response program. And since fiscal year 2018, grant recipients have served over 1,800 rural communities across the United States. And I'm always so impressed with what I hear coming out of that program. So those are a few of our accomplishments in the second year. And I'll just note, not take long with this, but we are doing a lot with monitoring and metrics, both in process measures and outcome measures, and assessing our work and what impact it is having. In terms of kind of what's happening now and what's on the horizon, one thing is these emerging threats. And so one example is xylazine. We've been working quite a bit on this. I've personally been very involved in this with ONDCP, our Office of National Drug Control Policy, who stood up an interagency working group on fentanyl adulterated or associated with xylazine. That's the FACTS acronym. And it was declared an emerging threat. We have worked on a response plan and are now working on an implementation report. HHS has many activities around treatment and best practices, testing, communications, and detection and surveillance. I think this is an example. It's a good playbook for how we might tackle these types of emerging threats. I think it raises a lot of questions around how we can optimally surveil for these types of emerging threats. Do we have the data with which to do so? And then how we can optimally inform stakeholders and the broader public about these emerging threats. We've talked a lot about, when best practices are not yet established in this realm of how do we treat wounds that are associated with xylazine adulterating drug sources. And so trying to kind of get information out quickly, but also be confident in the clinical soundness of that material as well. In terms of addressing gaps and going forward, we have a few areas that we're particularly focused on. Continuing to think about prescriber education, including across multiple different types of substances. Thinking about the naloxone availability barriers, as I mentioned, including with the shift to over-the-counter. Treatment, a real big focus is stimulant use disorders, and thinking about the research and what NIDA and NIH are doing and what are the most evidence-based treatments, including medications, a lot of research going on there. But then also what we have established as the best evidence-based treatments and how to actually scale that up and make that available, contingency management and other behavioral health therapies. In terms of recovery supports, and it delights me to hear more about this from other presenters, but I think what we've noted here is our data are really lacking on this workforce and on these services that are being provided. And so we're thinking more and more about how we can establish baseline data and really track this field more closely. So I think I've covered most of those. The two other things I might mention as future directions and foci are the telemedicine flexibilities, including working, this is really under DEA's purview, but those associated with an in-person examination before prescribing controlled substances and buprenorphine specifically. And so HHS is just consulting on that, but a lot of activity happening there. And then also we're thinking a lot about special populations. For example, the mother-child dyad and children and really early upstream prevention, and then criminally justice involved populations. We have established with DOJ OTPs in many prisons, but we have a long way to go there as well. So with that, I will stop, and that is my email. And I just want to close in saying that it's a privilege to hear all this wonderful research, and that we do consume it within HHS and appreciate it, and it grows the evidence base to help inform these types of policies and where we put our dollars and our efforts and our resources, and can help to work with states and all of the different stakeholders in effectuating policies. So thank you so much for all the work that you're doing.
Becca, thank you so much for joining us, and I know you're going to be heading out to the airport, so safe travels, and thank you for making time for us, and we will continue to make sure we're sharing with you the work of our grantees and making those connections. We're going to move right into our next panel, so I'm going to turn the podium over to my board member, Dr. Schottenfeld, and we'll ask the panel to come up, as well as our two commentators, Lakeisha and Dr. Jones, who I understand has arrived. Yep, there he is. Okay.
I'm going to moderate from down here. So this is, yeah. Good afternoon. I'm going to keep my remarks very short, just introduce people because we've got a full panel and two respondents, and we want to have a little bit of time for some questions. So for this afternoon's this panel on community-driven responses to the overdose crisis, we've got 4 of the 4 grantees who will talk about their projects. And then I'll introduce them and then the 2 discussants. And I will make one comment. It's just been a thrill to watch the interactions that have been going on today, to be seeing people networking, connecting, hearing about different projects, because in many ways we run the risk of working in silos and in isolation. And it's opportunities like this, and it's opportunities especially in forums that bring people with very different perspectives and doing different types of work together to be able to be thinking, what can we learn from each other? What do I need to learn? What are they doing? What can I take with me? So we'll get to play with some of that, and then you've got the grantees have more of that later today and tomorrow. So on the discussants, the grantees are, start with Nab Dasgupta, raised his hand. There he is, senior scientist, UNC Chapel Hill Injury Prevention Center. He's got one of the innovation grants, timely and actionable data, and we'll be talking about the drug alert system and how that's how he's been using that. And we've got Christine Gingery there, executive director of the Morgan County Partnership, Project Resilience, addressing ACEs in Appalachia, and this is one of the payer and provider strategies grants. And we've got Rafael Torzueja, and I've been working, but I can't still roll my R's, but I'll get it. He said it's Rafi. So, executive director of Intercambios Puerto Rico, La Movil, and it's one of the community-driven response grants. And then Jason Lindell, faith-based, raise your hand. Yep, good, I missed it around here. Faith-based support specialist for the Agency for Substance Abuse Prevention in Alabama. And they have one of the innovations addressing stigma grants. I think I'll introduce the 2 of the discussants afterwards, or respondents to it. So first on my immediate right is a fellow FORE board member, the Reverend Dr. Lakeisha Walren, who's the president of the New York Theological Seminary. So it's a pleasure to share this responsibilities with you. And then a great pleasure to welcome Captain Christopher Jones, who's the director of the Center for Substance Abuse Prevention. And I would read his biography if he were speaking separately, but we're going to keep the talk short. So I think what we've asked people to do is talk each one for about 5 minutes or so about your project. Then we'll have some general questions, I might ask and among us, and and then get the respondents. So I think it starts with Nab.
Great, thank you. Good afternoon. Hope everybody got a good lunch and is totally awake now. We know the drug supply changes, and even within a single neighborhood, the drug supply on any given day can be different from place to place. But right now, we don't find out, actually, you can just not show the slide for a second, please. Always one step ahead, these four people. But we don't find out what's actually in the drug supply until it's too late, when people are either dead or they're arrested. So we created a system where we can test street drugs and provide those results back to individuals so they can make better decisions about what they put in their bodies. And so the way that we have done this is we've created I was sitting in a COVID drive-through testing place early in the pandemic. And I was like, hey, if we can take a swab and put it up our noses and put it in this liquid, mail it off and get results the next day, like, why can't we do that with street drugs? And that's what we did. And so we have a mail-in drug checking program. And now we can see the next slide, please. And, oh, I can click it up here, all the power. So in the last year and a half, we've tested about 3,000 samples. We've had drug samples from 31 states and 143 harm reduction programs and others. And the folks who are sending us the drug samples are a mix of harm reduction programs, health departments, EMS, emergency departments, and drug user unions. What's the coolest thing about this? I'm a data nerd, right? And I'm an epidemiologist. And I was like, oh, this is going to be so much cool data. And that's actually turned out to not be the most interesting thing that's come of it. Even that stuff is cool too, right? But what we've been trying to do is this is not a research study. This is a service. It's a public service of a public university. And we are using this as a way of citizen science for letting people answer local questions, and we're giving them the tools to do it. And that's been the coolest part, is watching what happens when you liberate tools and then just step back and not require too much of the programs. So even though, okay, so here are some examples, and I'll run through these really quickly. So there was a drug user union in Nevada who wanted to know if they can detect xylazine or fentanyl using black lights. And this was like a street rumor. And so we worked with them to figure out how to sample representatively in their local area. And then we ran the lab test blinded and gave them the results. And you know what? They didn't report back to us what the answer to that question was, because we don't really need to know. They need to know in their local context, and it's not going to be applicable anywhere else. So that's kind of been the theme, is like we only hear about these anecdotes of how people use this post hoc, and it's not what people are using this for way cooler things than we could have thought of as when we started. So a group in Texas was interested to see if there was fentanyl in the black tar supply there. And turns out in one of the cities in Texas there is, and the other 4 there isn't. There's also like very hard things that happen. So widows of people who have died from an overdose, whose partners have died from an overdose, come and say, like, can you test my partner's meth pipe? We think he might have had fentanyl in there. He's not a fentanyl user. And so counteracting the 8 months it takes for autopsy results to get closure more quickly to individuals. A group of sex workers in Western North Carolina thought that they were being roofied, poisoned by some of their clients. And so they surreptitiously got samples, sent them to us, and based on those results, yes, they were being manipulated, and they were able to make a list of clients that they would no longer service. And so we get like a lot of these really fascinating local experiments. Like, does the meth supply get worse after local police raids on manufacturers? The answer is yes. The supply comes up from Atlanta and is much different than what people are used to, and that causes a lot of health problems. So, so when we get these results, the next thing is like, how do we communicate these findings back to people? And that's the second aim of our study. And so if you go, oh, I can do it. To that. So drug alerts are issued every day, and they're done by like all these public health agencies and law enforcement and, you know, harm reduction groups and everybody else. but honestly, they look like crap. Like drug alerts are like some of the ugliest pieces of health communication you'll ever see, right? I'm sure your agency has put out something that looks like the one on the right. I know our agency has too. And so we've been working with colleagues in our advertising and health communications field to redesign drug alerts. And so and so we're doing it as to build the evidence base for this. We're doing a randomized trial in 7 certain service programs to figure out like how to modify and manipulate the visual communication of drug alerts so that we don't encourage risk seeking for potency alerts. We can get information about adulterants at a understandable level, and really kind of the amazing, like working with actual VizCom people makes me like embarrassed about like anything I've ever produced visually, right? And so something like this is one of the stimuli in our trial. You know, it's very simple. It's the same information more or less as you see in the control group, but it like just the size of the font, the call to action, the visuals are all very carefully calibrated to be at a cognitive level that gets people to take action and not just read. So the number one thing that I've learned from this process is that we need to disentangle alerts from information. And those need to be different visual formats, different medium. But if you want alerts, they need to be short and really short and make them even shorter. So that trial is starting this week, actually, today, Thursday, tomorrow. That'll kick off. So we'll be having results from that by the end of the year. We'll put those up as Word templates for anybody to use and have best practices guidelines. So I'm really thankful to FORE because we went from concept to like a full-fledged drug checking program in just over a year, thanks to this funding. And it's really been a leap of faith, and I appreciate what you all have done for us. Thanks.
Kristen, you want to come up next?
All right, good afternoon, everyone. My name is Kristen Gingery, and I'm the Executive Director of the Morgan County Partnership and Principal Investigator under our FORE grant. So we are one of the community-based projects addressing ACEs mitigation and trying to reduce the impact of trauma. My agency, Morgan County Partnership, is a 501c3 in rural West Virginia. And our primary focus areas are supporting substance use prevention and mental health promotion among youth and families in our rural community. And so when this funding opportunity came available to us, I realized that we can't support the community without working with our partners. So we actually have 4 sub-grantees under our project, one of which is here today, the Martinsburg Initiative. They work very closely and do similar work in our neighboring county, providing extensive social work supports in a PK-12 system. We primarily provide evidence-based substance use prevention curricula in our rural K-12 system and intensive mental health support. So we have a K-5 therapeutic support program that we screen and provide evidence-based mental health models to use K-5, and then a FORE program. So we have a screening, brief intervention, and referral to treatment, and we screen every ascending 6th through 12th grade student in our public school system for trauma and for substance use and risky behavior. So that's one of our pillars that we've been able to use for this funding. We also partner with Starting Points, which is a local family resource center, Life or Drugs, which is a grassroots recovery support group network for our community, and then CASA of the Eastern Panhandle. We've heard some themes of working with justice-involved families throughout this morning, and I myself am a CASA advocate, so if you're not familiar with CASA, they're court-appointed special advocates. And in our community, 90% of the abuse and neglect cases and going through our criminal justice system are directly related to parental substance use. So I hope that paints a picture of our families and the services that are needed. So Project Resilience, our primary goal for the project is to mitigate the negative impacts of trauma associated with ACEs for our youth. Primarily, substance use is our primary focus for this project. And our goal was to create an evidence-based initiative to not only address root causes of trauma, but these generational patterns with families in our rural community. And our goal was to primarily bring all of the service providers together under one funding mechanism, reduce these siloed approaches, build this village to support our children in our rural community. We do a variety of supports under our FORE project, from trauma-informed educators series with support from Margaret and the Martinsburg Initiative to after-school supports in our MC After 3 program. We also provide free therapy, which is very important for rural Morgan County, West Virginia. We've got extensive 6-month waiting lists for private practice therapeutic supports for youth, and we are able to circumvent that and offer direct graduate level social workers or therapeutic counselors working directly in a K-12 system free of charge to families. And then we also partner very heavily with our court-involved families. So those abuse neglect cases that we mentioned, every case in Morgan County has staff working through this FORE funding with these parents. So we've got parent advocates, parent advocates working with the adults in abuse and neglect cases to try to help them navigate these improvement period terms, working towards reunification and restoring families. And then we also have an arm of this project where we offer private practice parent-child psychotherapy. So we have a licensed professional counselor who's not working in the schools and only taking referrals from the court system for our most crisis high-needing families. So that's one model that we think is very useful. So within our first year, we're just at the 1.5-year point, but I'm reporting some numbers for our first year closure. We were able to provide support through the Morgan County Partnership to 471 youth in our public school setting. So these involve Tier 2 group therapeutic services, and then Tier 3 direct trauma-focused therapeutic one-on-one sessions, and then a variety of Tier 1 prevention programs universally throughout the school system. The Martinsburg Initiative has been able to provide 311 interventions focusing on case management, ACEs mitigation. Our grassroots support recovery center, we've been able to open a recovery resource cafe, which for our tiny community of 17,000 residents, we had no recovery resource center, no walk-in, drop-in facility for community members to come in and say, we need help, we need access to services, where do we begin? We now have that because of FORE, and we are so grateful. And parents are able to have case management services and 3 different recovery options for meetings every week. Starting Point, our Family Resource Center, has been able to provide the parent education component. So for adults who are involved in juvenile abuse and neglect cases as offending caregivers, they are often court ordered to have parent education, and Starting Point provides that within this funding, and also has a Healthy Grand Families program. So we have 30% of our students in Morgan County schools are being raised by a non-caregiver or parental caregiver, most likely their grandparents. So that's a high need population that has low access to resources, and often is an older population that doesn't know how to raise grandchildren in this day and age. So we provide supports to them as well. And then we've worked extensively with CASA to launch this Fostering Futures initiative. So it's a national model under the CASA lens, but we did not have a regional program here. And Fostering Futures focuses on working with adolescents who are in foster care who are about to age out of services. So losing all severance of supports from the department. So this is a high need population that has low access to supports. And then another parent advocate model supporting those families in the judicial system. So that's kind of our work in a snapshot. But I can't say how grateful I am to the FORE Foundation and to other funders in the room who are willing to continuously support projects in Appalachia and really hard need families who really have marginalized risk factors and low access to services. So I thank you wholeheartedly.
That's really wonderful to hear about the interconnections of services that what you're trying to weave together there to create networks of support and connections. So that's great work. Rafi. I'm gonna come up.
So good afternoon. My name is Rafi Torruella, and I'm really, really happy to be here. My first time around FORE Foundation people, so it's like happy to get to know all you folks. So when they asked me to present the organization in no more than 5 minutes, only 2 or 3 slides. So can you put the next slide, please? Then I decided, well, what can I show? Well, the amazing team of people who I work with, right? And that's just the part of the team. And the actual push of Intercambios and what we do is a harm reduction organization that goes from syringe exchange program to mental health clinical services and outreach services. So we, from a harm reduction perspective, not only engage people who use drugs in the places that they do use drugs, in shooting galleries, and directly provide primary prevention like syringe exchange programs and mind meld with them to see what the substance is like, what's happening, what is the market looking like, and all that, and through all the way to providing mental health services in a clinical setting, right? And we do most of this. I would say 95 to 97% of our work is doing outreach out in the community. So you can see the mobile vans that we have behind the team, and that's just who we are. T-shirts or polo shirts and shoes and tennis shoes, and we are community-based outreach organization. The other thing I thought is like, well, not everybody knows necessarily what the geography of Puerto Rico is, but I think it's wound up being a little bit too small, but we're on the eastern side of the island. We provide services to about 21 communities in 10 municipalities, and not all of it would provide the whole range, right? But most of those services, again, are doing outreach, and we go, as I said, from syringe exchange program to clinical services, and then the whole kind of in-between world that we have: case management, navigators, social workers, and an array of services. So what we want to do is engage the people who use drugs and provide them that harm reduction perspective and care that many times, regretfully, they don't find when we refer them out. So that's why we try to expand a little bit that care continuum through doing outreach. Next slide, please. So then, particular to the goals and what we want to do with this new grant that we have from you folks is support and expand the current harm reduction overdose focused services in Eastern Puerto Rico. And that area, we were already doing work, and now this is scaling up the work and making it even that much more professional and solidifying us as an organization in this area. And particularly, we want to expand the licensing with local state regulatory bodies, and that's why I say I have an amazing staff. We had a goal to only submit for 1, and now we've submitted for 3 permits. Puerto Rico is like very heavy in terms of bureaucratically, but we want to be an outpatient substance use center. We got that, and then we also applied for MAPS and other prevention and medication handling and storage. So we've like overshot it because amazing people working for us. Then we wanted to design a survey for community and hospital-based pharmacies to see BUP availability in different communities. When we started talking to some friends, they said, oh, the School of Pharmacy, we're doing that same thing. So now we're coalescing with the School of Pharmacy at the University of Puerto Rico, and we're doing together that survey across pharmacies, not only in our area, but then they're going to do a big part of the island. So a small project that we said, let's see how we can respond better to our participants, and the pharmacies turned out to be a really strong collaboration with the University of Puerto Rico. And then we wanted an assessment of emergency responders and overdose training in the naloxone. So we saw that emergency responders were already trained. So we started then not only seeing who we wanted to train, but then started doing overdose training and naloxone distribution across different areas in the south part of the island with the Ponce School of Health and other community-based educational centers. We reviewed the outreach plan, and just to give you a little flavor of how we do stuff and how we provide care, these are a little bit of a breakdown of the from April to May participants that we have. And basically we provide home ulcer care Because in Puerto Rico, I don't know if people know, but in Puerto Rico, we've had xylazine for the past 10 to 12 years. So xylazine, when I hear, oh, xylazine is new, nobody uses it, it's like, sorry, wait, we've been doing this. And I guess we want to talk a little bit of that today in the panel too. So we go to homes and do that also care that otherwise, people will not open their doors to treat this big gaping ulcers, except for us because of a harm reduction methodology, because we have been there from when they started injecting, to when they went to treatment, when they went to MAT, when they came back to the community, and now we provide it in home care. We also link to services. We also provide transportation and advocacy, because regardless the stigma, as we were speaking this morning, stigma is so strong that many times when people who use drugs go directly to provide services, they're turned around or they're not provided services adequately or in a timely manner, because we know many times waiting times could be 6-7 hours in an ER, and many times they do it wantonly, right? Like they don't provide care, and we know what happens to a person who needs to use fentanyl or heroin. Then they fall out of care. One participant died, and then we have 6 in MAP, and then we provide housing support. That's just a little glimpse of what we do at Intercampus. Hopefully we can engage this in more conversation. Thank you.
So, Rafi already alluded to one of the issues that we're going to ask the panel to talk about, which is this: how do we use what people are seeing in different communities to inform what people are preparing for, and get really early alert systems in place? And I think we've already heard in these different ways some very nimble systems trying to respond to what we know to be fast evolving drug problems. It's not one problem and it always stays the same. And the people who are always ahead of us are the ones who are engaged in the active experimentation and use. And we need to learn from them. And we can learn a lot from them in terms of how we adapt what we're doing, what we're responding to. And so I'm going to challenge panelists to have some discussions about that. So, but first I want to bring up Jason and talk about one of the types of responses through the faith-based.
All right, good afternoon. All right, well, if you've waited this long, it's about time you got somebody without a doctorate in their title. So my name is Jason Liddell. I'm a prevention coordinator with the Agency for Substance Abuse Prevention in Oxford, Alabama. I used to think we were a rural community, and then Alaska came up here and talked about snow machines and bush blades. So you mentioned the S word where we are, and you won't see milk or bread for 2 weeks and school let out for one. So how we got here, and before I get into our faith-based support specialists, is listen, I'm prevention. We're not a data, I'm not in treatment, we're not in recovery. We are in strictly education and prevention. And we service 6 rural counties in Alabama. And when I first got in prevention, we all have the same goal and we all have the same mission, and it is to fight the substance misuse epidemic. And at the time, it was heroin. And when we had people call our office, whether it be for, hey, my brother, my family member is hooked to this, what do? I found myself doing a Google search. And to be quite honest, it was kind of embarrassing. So we created what we call a opioid roundtable, where we brought people from the treatment centers, the community, business individuals, ABC board, DA's office, law enforcement, also religious leaders in the community. So to sit down, have conversations about what is going on, what we're seeing, and how to combat that. So throughout our conversations, we, especially with our religious leaders, we found that people with substance misuse issues a lot of times turn to the church or the religion during that time of crisis. We found that the churches were not equipped, prepared to help these individuals. A lot of them, and listen, I'm from Alabama, so you got a lot of Baptists, they would pray for them and send them on their way, which is, as we all not the best thing to do, right? So, all right, to the right. Boom. So throughout those conversations, COVID hit, we had made some great strides, and our overdose numbers had dropped to almost single digits in our county. Not quite there, but obviously when COVID hit, the resources, the things that individuals were used to having were no longer there. Our numbers slowly started to go up. My best friend from high school and a groomsman of my wedding was one of those statistics at that time. So what we found was he turned to his local church, and they did not have the capacity to help him or turn him in the right direction. So through our conversations, we came up with what we call the faith-based support specialist program. We pitched it to the Alabama Department of Mental Health, and what we realized that most ministries equipped to handle ours, or let me back up, sorry, I got 5 minutes, I'm rushing. Are most ministries equipped to handle substance misuse issues? Most of them are not. People that turn to their faith, whether it be churches, temples, mosques, at that time of struggle or need. So what we found out, what we believe is prayer, prevention, and treatment do work together. So what we do is we have the training. It's a 2-day throughout the state of Alabama. We've been to 7 different, over the last 2 years, 7 different communities in the state of Alabama. It is a free 2-day conference where now these religious leaders, and to be honest, we used to, at the beginning, we said senior, but we found out your youth minister is almost as important as the head guy in the church. Because who's he going to deal with? He's going to deal with your youth, your children, things of that nature. Your music minister, so anybody now, it's turned into, if you have a role in that church, you are more than welcome to come be a part of this training. It teaches them some of the practical stuff. Listen, when we began, my dad was the guinea pig. My dad went to divinity school at Vanderbilt University many, many years ago. So I came home when we were talking about it. I said, and he read to retrain to marriage and pastoral counseling. And I said, Dad, so if you would have someone come to your offices and say, hey, I'm struggling with this substance, what would you do? And he thought, and I said, wow, this is taking way too long. And he said, well, I would find a former client or a client who was struggling as well and get them connected. And I kind of took a big breath, and I kind of smiled and nodded and thinking, okay, so there really is a need for this. So these pastors will go through training. Listen, we're backed by the Alabama Department of Mental Health. So all the vendors that come are backed. They're certified. All the presenters are certified, which if, I don't know, in your area, you've got some that are a little non-certified. Let's just put it that way. But they will be taught in assessment. Some of these religious leaders don't know what an assessment is. They think treatment is just, whoa, you're addicted to meth, you're addicted to, isn't that, I can send you treatment. You've got to meet people where they are. Someone said it numerous times earlier. I'd written that in my notes. If I've written it once, I've written it a million times and said it during this. Meet people where they are. So they learn communication skills. Religious leaders are taught to talk, not necessarily listen. So we try to teach them communication, but also to be an effective listener. Because if you just are quiet for a second, they will tell you a lot of times what's going on. So it's a great product. We've done it 7 times throughout the state. We've actually in Mobile had a group of pastors form their own coalition. So they are meeting independently. Because for me, I'm 6 hours from Mobile. I can't be at your meetings every other week. So it's a grassroots effort where if we feel like if we can impact the head of the church, then it will filter down to the body of the church. We appreciate FORE's partnership. To be honest, I kind of blame FORE a little bit. So when we do our Zooms with Ken's like, hey, if you talk to this person in Tennessee and this person in Ohio and this person, so now I had coworkers that did a training in Kent, Washington 3 weeks ago. You called me from little old Oxford, Alabama to come all the way to Kent, Washington. Listen, when we were talking about this, we tried to find a will to copy. We could not find one. Now, there's great programs that do the congregation, but we specifically wanted to target the heads of the facilities. So now, because of FORE's involvement, we are having a national conference in December where we've already got 18 individuals. We just released it last week. We've got 18 individuals from all across the United States who have registered to come to Birmingham. So again, thank you for your partnership. We'll be up here asking questions, answering questions before. Thank you for everything you have done so far.
Well, thank you, Jason. And you misled us though at the beginning. You said you weren't a data person, and then you kept talking about all the data, because data comes from listening. You know, it is really a primary data collection vehicle to be listening and thinking and looking and trying to figure things out. So I'm gonna start and ask some general questions. So first, you know, we said we were seeing evolving trends, evolving changes, and I'm wondering for each of the speakers, what are the things that you're seeing now that look, you know, are new and that seem to be heading towards a change from a couple of years ago, even? And I think you're all seeing it in different ways. So I'm going to probably pick on Morgan County first. You know? Sure.
Is this on? Okay. So what are we seeing now? We're seeing increases in adult involvement for abuse neglect cases related to parental opioid use. We're seeing backlogs from our Department of Health and Human Resources for those CPS cases coming to fruition. So we're seeing more involvement with parents in the court system, which leads to more trauma and segmented families within our school system. But we're also seeing needs being met. So on the positive side, you know, even though trauma has occurred, we're able to provide responsive efforts to try to support our students, even though they've experienced a trauma related to parental opioid use. So I think about the smiling faces on the students when their character education facilitator comes in and teaches them about how their thoughts affect their feelings and their feelings affect their behavior, or our adolescents who just need, you know, group therapeutic services with peers who are experiencing similar outcomes in their family unit, and watching students who, if they didn't have a support person, like in our alternative ed program, who have a social worker supporting them, make it to graduation last year, and we never thought that was possible. So small things like that. Yes, we're seeing an influx in adult substance use, but I think we are being able to be more responsive to the youth who've been impacted related to those increases. So I'm happy to meet the needs for the kiddos. I'm sorry the parents are struggling, but at the end of the day, if we can provide a support mechanism for one child, it's all worth it.
Great, thank you. Yep.
So speaking very much like of what's in the drug supply, you know, xylazine we're seeing, of course, but we're also seeing places where there isn't xylazine and we're actively looking for it. So like Nevada, New Mexico, Washington State, California, very, very little xylazine. And the same with how much fentanyl is in meth and cocaine. It's also very variable by location. We see it much more on the East Coast than and very little on the West Coast in the fentanyl. We're also seeing nitazines, which is not surprising, but what's been interesting is that of the different nitazine compounds, different parts of the country seem to have different preferences. So like Tennessee is metanitazine, and you know, other places will have more protonitazine. We're working with pharmacology colleagues to figure out kind of potency and predicted harms from each of those. And then with xylazine, we're also starting to see the cousin molecule of xylazine, dexmedetomidine, start to emerge as xylazine gets more cracked down on. And we're also seeing xylazine like a little bit more involved in sexual assaults and other assaults in ways that, I mean, it's like every time you say the word zombie or tranquilizer, it's like an advertisement for people to use it for knocking people out. And so stop using those words, please. And then finally, the kind of really unexpected thing we've noticed is an emergence of actual counterfeit oxycodone showing up in fake pills. Because oxycodone is kind of hard to manufacture, but apparently figured it out. So we're just starting to see that in the Pacific Northwest.
So in a way, you answered one of my next questions, or you gave at least one response, which was if we took the data that, say, Rafi had been seeing about xylazine 10, 12 years ago, how might we have used that in places where xylazine wasn't already a problem to prevent that? And, you know, and I'll start, you know, you said, well, one is we need to think about what makes a drug attractive, and then try to pull that away early on in terms of how you message and talk about it.
Yeah, I mean, I've known Rafi a long time, and I knew what he was doing, and we used those data to inform our responses immediately. You know, we were just able. That's really what's been interesting, is because, like you said, you know, people see this as a new thing and forget. But if you have like local folks who aren't drug nerds, who haven't been following the literature for 15 years, like, it's an easy thing to miss. So as soon as we can make that connection in, shout out to y'all.
What we are seeing is that xylazine and a long dated history. Islands xylazine and without xylazine, those became perfect. Stop doing that work. So then it's for people, right?
So it's in the, oh, much better. Wow. I have faith. Wow. So we're seeing less xylazine in Puerto Rico. Of course, there's an increase in fentanyl, and which is a little bit different from other places, right? That are seeing an increase in fentanyl, obviously, and then xylazine at the same time. Also, we're dropping one and then picking up the other, because that's just how the market is going. But it's interesting that we don't have that much xylazine. You can find it, and you know it because you see it again in the body. So people, you see the ulcers that we go treat. They're big open ulcers. It's not just an abscess of regular version, and we tend to that. So that's kind of like on the market side. On the service side, we're still seeing a lot of stigma and discrimination from providers. That's a very, it's still a reality for people who use drugs. So people who use drugs then leave the island in order to receive treatment, or what they think is treatment, because you have then the relocation of people who use drugs from Puerto Rico to the mainland, and then that becomes its own problem, because many times they're used as, that's when people who use drugs then are valuable to other people, and they receive treatment in non-certified locations, right? And then they bill for it, and there's this whole different level of what we understand as treatment and what people who use drugs might be sold as treatment, right? So there's that. We're still seeing that type of behavior, and then we're seeing also that a lot of people now, well, there's some, for example, FQHCs and other big hospitals now begin to provide services to people who use drugs, but because the stigma and discrimination is still so there and present, people don't go to them. So suddenly you have a lot of money being rolled out by mostly HRSA to different centers, which might have 3 or 4 folks in treatment. They have a whole range of, the whole services are there, but they're not going in the door. And part of the reason is because it's still a very top-down model. It's a model that is not, again, mind melding with probably your local syringe exchange program, you know, and your local syringe exchange program will not refer to these places because they know it's a different type of care, which is very, you know, still heavy with stigma.
So I was thinking, and then we'll get to Jason in just a minute, that you know, some of these changes in the patterns, you know, you describe, say, that now the decrease in xylazine as there's full awareness of really the effects on the body,
right,
and how awful it is, and that finally that begins to shift. So the harm reduction is some part of it with people who you learn to believe or you see with your own eyes, where you say, that's not for me, and turning away from it. It also then, of course, raises the questions as new substances come in, what's the non-harm message that's coming in? What are the pleasures and impact that's being talked about, bandied about, and are there earlier ways in the networks that you develop for harm reduction of saying, yeah, it sort of looks great at the beginning, but it's a version of that, or it has that effect, and do people believe it? So I sort of raise it both as a question and as a comment. And the other question that I had was, how do we, and this is, I think, for all of us, is how do we embed, we have these different systems, and we have a lot of interactions here, but Rafi just talked about, we have this effective harm reduction network that's trusted and connected, and it's kept out of some aspects of the large healthcare, the federally qualified healthcare and the main providers. And as a result, some aspects of treatment are starved off and resources aren't being deployed. And, the organizational question is, how do we create some not forced marriage, but something where people embrace and say, I can learn from you. I can bring in harm reduction. We can have it in our FQHC and not just have it as an ancillary, but as an ethos.
Well, how does harm reduction become part of the continuum of care, right? Yeah. So we rarely think about this type of stuff, right? Because some people do work with their syringe exchange program, but just expect, well, just send me the referral and then I'll take it from here. But the patient really starts when they come into the FQHC, the clinic, the treatment program, whatever have you, whatever the referral, rather than thinking your harm reduction providers being part of that continuum of care and being integrated so information can flow, and you can track participants better because they fall out of care and they come back to the community, right? So integrating harm reduction organizations and programs within a continuum of care and being part of that. What does that mean for Medicaid billing? Then that's not all ball of wax, but that is happening in some states like New York, right? That was the model, integrate harm reduction into the continuum of care. But how are we doing that in the different states or territories is still a question that many times there is no relationship.
So this is, of course, a great opportunity as we think about ways in which Medicaid can be shifted, experiments can be done to be creating incentive models for payment, either model programs or payment models that would incentivize and allow that and encourage it. And then, Jason, thoughts about what you and so what the ministers are seeing as the things have changed.
So with us in Northeast Alabama, I-20 runs right through us for substance misuse, and we're still in the fentanyl, methamphetamine era. It's kind of, yes, there was an opioid epidemic, but for some reason, methamphetamine never left our area. And the big thing we do is just education, because with the xylazine, it is not hit yet. So the goal for us is to, hey, sometimes you feel like a stockbroker because you've got to be on the cutting edge and let these people know before the wave hits. So that's where we are. Counterfeit pills is a big one. We've also partnered with our coroners. It sounds a little gruesome, but if you want to educate, you need to get to the source of it. Now, and it's harder in our rural areas because in our main one, we've got a partnership. He's got the EDRS system, so I guess other people in my office have access to his data, so we can tell what they're overdosing from fairly instantly. Whereas when you get to the rural areas, now your coroner is all of a sudden he just owns the local funeral home, so it's a little bit more difficult. But for our area, it's what we do in prevention is just strictly try to pay attention, listen to what's coming out, and then educating the community on what's possibly coming down the road and the things to look for as well.
I'm going to look at my timekeeper. Am I supposed to switch about now? Yes. Okay. So I'm going to ask the commentators and maybe start with Reverend Walter.
Sure. Thank you. Good afternoon. Good afternoon.
Good afternoon.
And I'm just so grateful to be a part of this day and to be a part of this conversation. Certainly after hearing Dr. Dasgupta talk about this leap of faith, Kristen talk about the importance of resilience, Raphael talk about this need for us to pay attention to our continuum of care, and Jason talk about the power of prayer, prevention, and treatment, right? I've heard just several themes that have come up, and I want to just reflect on those themes. And the first is this notion of community and the fact that we're not alone, and how sometimes this work can feel like very lonely work, especially when we don't see the results that we anticipate. But for us to all be reminded that we're not alone, that this work that we're doing is important work. And if we just look around this room, we recognize that as often as it feels like we're in our offices or our cubicles and we're doing this work and sending these emails and trying to write these grants that are going to be funded, that you are not alone. The second thing that really kind of rose in this conversation is this notion of resilience. And for me, as a woman of faith, it reminds me about the importance of recognizing the seasons that we're in. I'm a country girl from Texas, and my great-grandparents had a farm, and sometimes we want to always be in the season of celebration and success, but that's not always where we wind up. Sometimes we're in a season of working. We're actually having to do the research, write the grants, find the partners, the participants. Sometimes we're in a season of sowing where we're actually doing the work, doing the implementation, implementing, educating. Sometimes we're in a season of waiting. That's a hard season when you're waiting on the results and to come back, waiting to hear back from the funders. And sometimes then we're also in that season of celebration. But sometimes we can get discouraged when we're in the season of waiting or we're in a season of working. But to not get discouraged because we know that celebration is coming. For we have to encourage ourselves not to grow weary in doing the hard work, but we will reap if we don't give up. So just want to encourage us all to continue to recognize the importance of the work, and in those moments that we feel like walking away, just to remember that we're just in a particular season. And then finally, just really the importance of faith in this work. We know that faith can be as helpful as it can be harmful, especially when we encounter spaces of faith that tell us that we can pray these challenges away, right? And we know that we cannot pray them away. It has to be prayer and faith and prevention and treatment, this resilience that allows us to continue to move forward. And so recognizing that our places of faith are places that can empower us, because we not only have faith in higher beings, we have faith in ourselves, we have faith in the medication, we have faith in the treatment, we have faith in the plan, we have faith in the research. And so this notion of faith can stretch across so many different areas. And so I want to just make sure that you all leave as inspired as I am right now listening to all of these panelists, and that we remember that we're not alone, that we remember that we are resilient, and that we operate in seasons, and that ultimately in communities where we recognize the good, the bad, and the ugly, we recognize that we're all people of faith in some way or another. So continue to be inspired and continue to be encouraged. And just finally, I want to thank you all for bringing the work of FORE to life. You have given it arms and legs and voice today. We sit and we read your proposals, and it's words on paper, and we try to imagine in our minds how it's going to work out. And today, you all are showing us the importance of this work and the fact that the hours that we spend reading these proposals are making a difference in the communities that you're serving. So continue to be inspired, continue to be encouraged, and continue to participate in this great work we're doing.
Well, I'm no longer tired. What a powerful message. What a powerful message. So, and we're going to ask Captain Chris Jones, who's the director of the Center for Substance Abuse Prevention of SAMHSA, to make some comments too. Although I got to tell you,
An
I hate
impossible
following
task.
a preacher. You know.
I don't know. Okay, there we go. Well, thank you for the inspiring words, and thanks for all of the work. And I am having I'm a sloucher naturally, but these chairs with the uniform, I don't know. It's like really hard for me to sit up straight. It's just like I might be on the floor. Just a couple of thoughts. In thinking about each of the speakers, what was remarkable to me was that it really reflects the scope of the problem that we're facing, right? So some folks are really at the edges of working with people who are using drugs, trying to prevent harm, and then others are working very upstream, right? And it's not one or the other. We have to do all of those things and everything in between. And I think from a policy perspective, it's often like prevention is pitted against harm reduction, or treatment is more important than recovery, vice versa. And I think it really underscores that we all have to be working together, that we do all have a role to play in that spectrum, and sort of gravitating to what makes sense for where we sit in a community, whether we're parents, whether we're teachers, whether we have, the ability to create jobs or provide housing, we provide healthcare, treatment, whatever it is, sort of embracing that's my piece of how I'm contributing to it, but everybody else is also important. So to me, that was one thing that I really like, the variety, right? It's not just one approach, but that we have to do all of these things. The second part for me is just the hyper-local aspects of this, and especially sitting at the federal level, it's so critical that we have conversations like this. Like, we're putting out funding, providing technical assistance, but we want that to be informed by what's happening on the ground. How can we not get in your way of being successful in doing the things that you need to do, but to recognize that it's also not a one-size-fits-all approach, that we have to understand what's happening in the community, what's the context in that community, to enable organizations to implement successful programs or policies or practices. And I think it's just a good reminder for us, for me as a federal person, to really be thoughtful about how are we getting money out the door, what are we asking people to do, and how do we embrace that sort of hyper-local perspective. And then the third thing that I wanted to comment on was just the undercurrent of harm reduction. Some of it was very explicit and some of it wasn't. And I think Richard was trying to make the point that harm reduction is not just the provision of services, but it is also a way that we approach this issue, a way that we approach individuals who are using substances with empathy and compassion, meeting them where they are. But I also saw that in the presentation of thinking about kids, youth, and families, right? It wasn't wasn't a punitive approach to parents who have substance use problems, but how do we support them? How do we support them as parents, even though they have problems with substance use? How do we set the family on a better path? To me, that is taking an empathetic, compassionate, a harm reduction approach, because we know that helping the parents get on a more solid path is helpful for the next generation, but we also can do things for that generation before risk behaviors show up. And so I think it's an opportunity to embrace that wherever we are sitting and working, to think about, are we doing this in a way that is meeting people where they are, that is embracing their humanity, that they deserve empathy and respect and compassion, and they may not be ready to do what you want them to do, but how can you meet them to do what is the next thing that puts them in a bit of a healthier place or on a healthier path, or that can reduce immediate harms that they may be facing to their health. And I think we're in a moment where we have to do that. The urgency of the issue really demands it. I think it is us in government, it's us working with communities, with faith leaders, with others in the prevention space, harm reduction, treatment, recovery, all of those things that Rebecca talked about, to sort of be unified in that approach, that we can think about these things differently. We can look at policy in a different way, clinical practice in a different way. It's, as a person in long-term recovery, I still get it. I go to the doctor and people don't understand, and I have to be an advocate for myself. And I have the knowledge to do that and the experience to do it, and to know that it's okay to say, like, no, actually, I don't think that's a good thing for me, right? But not everybody is empowered in that way, and they shouldn't have to be.
It should be that our healthcare providers who join the helping profession show up and want to help people in a non-judgmental, non-stigmatizing way. And I think embracing that idea of harm reduction as a theory, conceptually, as a way that we approach our work, can really shift how we are all working together. So I appreciated that it was there in everybody's presentation, whether explicitly acknowledged or not. So thanks very much.
So thank you, and I think you did get at the idea of developing a large community of support and moving away from models of war to community and communities of support and respect and understanding. We're all in it together, and we're all working on the same goal. How do we live healthy lives, supporting each other, where people get respect, dignity, are able to achieve what they're looking for? And that's the ethos, and as we convey it, and I think FORE grantees are brilliant at this and living it, how it's so important. So I want to thank the panelists, and they get a big round of applause. Thank you.
All right, we're going to transition into our last panel. I'd like to call the panel up. If we can get Tanya, Jason, and Thomas and Courtney to come up. Hello. Hello again. Very good. Yeah, yeah. Don't slide off the chair, please. All right. Yep. All right. And before we turn to our distinguished panel, and as we get set to talk about really people engaging folks with lived experience in this work at what a critical time, for the nation, really. First, we want to actually show a short video, and if we could, this video is of a peer recovery coach, and this is Lachey Whipple.
Drank when I was younger, so I grew up between my grandparents, and then whenever they would stop drinking, they would come pick me up. So I had abandonment issues. I didn't really realize a lot of things that happened to me until I got sober, and I took parenting classes, and I started having memories of things that had happened to me. My drug use had just gotten way out of hand. I had started
to the point of killing myself because I was pregnant. So I was like waiting to have her, and I was like, once I have the baby, I'm gonna give her up for adoption, and then I'm gonna die. That was my plan. So, you know, in that moment, I was just blown away by this woman who wanted to help me, you know, and then I started thinking about my mother and how my life mirrored her, and I couldn't keep doing it. I was going to change. I was going to be a mom for once. I was going to be a better person for once, you know, and I was just going to stop doing all the stuff that I was doing. And I knew I needed help, though. I knew I needed help because there was no way I could do it on my own. So as soon as I was able to, I got into treatment right after that. I feel like it was almost like being born again. I had to learn how to do everything. I had to learn how to be a mom. I had to learn how to be sober. My very first apartment was with Maggie's place with their transitional living, you know, and you know, and then we have a family coach that helps us. I was going to AA meetings all the time. I was going to counseling, but I was having a hard time, like, nobody told me about when you have dreams of using, how much it triggers your whole body, you know, all your senses. And I would call up my counselor and say, I'm freaking out. And she would immediately schedule me an emergency, you know, counseling session. I asked my supervisor, I was like, look, I need a meeting. I said, and if I'm struggling, I know other mothers are struggling too. So I think that's what makes my job is, hey, I'm just like you. I might work here, but I'm just like you. I started where you were. I started in the home, you know, and I just want to make them, you know, welcome them with open arms, just like any, you know, other meeting that, you know, I'm glad you're here. I'm happy you're here. I know you're struggling. I'm struggling too. So let's get through this together. You know.
That was great to continue the good feeling of today, right? Good afternoon, everyone. My name is David Mineta. I am proud to be a board member on the FORE board of directors. And of course, you know, so many years in doing this, I always start and I forget to introduce myself, and we're already moving along. So this panel is by design talking about folks with lived experience and the impact that not just FORE grantees, but you know, grantees across, I think SAMHSA grantees, other foundation grantees, other philanthropy grantees are finding that folks with lived experience are making a difference in so many different communities around the country. In sharing this experience today, we are very lucky to have 4 experts with us today to share some of their knowledge and again, practices and maybe challenges and things that we've learned along the way. So the first, we are fortunate, and I would say this is a very 2023-ish thing, is Google these folks. Right? Because we're only given this much time, but if you Google them, you'll get all this information about this amazing work that they're doing in their communities. So, so the first, I'd like to introduce Tanya Lord, PhD, MPH from the Foundation for Healthy Communities. Tanya led work with critical access hospitals in New Hampshire to improve care for people with OUD through co-design of care with patients and families and hospital staff. How innovative. Tanya.
Thank you, and thank you for saving the best for last. So I could talk forever on my project, but it's based on experience-based co-design. And essentially, it's a very structured way of co-designing with two different groups of people, whoever those two groups might be. So it's, for our project, it was staff and clinicians and patients and families. So actually, the families were harder to recruit than the patients for this project. Even though I'm integrated into my own personal family groups, I couldn't get people to come. But so we did focus groups with staff and clinicians, focus groups with patients, and again, we call them patients, but these are people with lived experience. I've done a lot of these type of experience-based co-design cycles. This is will probably be my favorite, is my favorite to date. And we were fortunate enough to include, because we were looking at acute care, the critical access hospitals, and how they were how patients were being treated when they came in with a substance use disorder, not necessarily for treatment, but for any cause that they were coming into the acute care hospital setting. And because of that, it was very important to us to talk to people who are currently using. And we were able to recruit people who were in, as I said, currently using. So with those focus groups, they generate problem statements that go into a co-design meeting where we bring those two groups of people together, and then it goes into the initiatives and to the co-design implementation. So that's the structure that we did. Then we did a lot of qualitative analysis, not surprising, and we've heard it here. And I so often report this to people who are resistant. So I feel now I'm just with family, and I don't even need to say that much because you already are seeing this and you know this. But empathy and stigma, we did separate those two just because there were so many times that people talked about just being treated so poorly versus with any kind of lack of compassion. And then the stigma being the very clear. This is the patient themes. I don't have the physician or staff and clinician themes specifically. Here, they were focused very much on, as you can imagine, in community resources and medical management. However, so they did not bring up stigma as often. However, these are the things we heard in the groups. They don't want to help themselves. They can't be trusted to tell us the truth. And this from a substance use physician, they lie 95% of the time and don't tell the truth 5% of the time. So stigma was alive and well. So we had to do a little where the qualitative analysis would not have pulled these out, we pulled it out. And when we presented this back to the staff and clinician groups, then outpoured story after story of witnessing stigma. It really opened it up. And when we brought these statements to, again, I just default to patients, but to people with lived experience, and I said, you know, there's a lot of talk about lying. That you come into the hospital and you're lying, and they're like, well, of course we're going to lie. You're asking us very personal information. And so as we talked about that, some of the staff and clinicians were like, wait a minute, when I go into the emergency room, I want people to, and they're talking about my private part, right? The same thing, just you're asking somebody asking somebody about drug use is extraordinarily personal, just like asking them about their genitals, et cetera. And then the concept, why I had a lot of pushback is why am I getting funded to do this kind of work when there's other people needing this more. What I love about the co-design process, experience co-design process, is we allow any idea to come forward. So we talked about, sorry, it's really hard to read those. I should have made them bigger. Right, so there's, so this idea comes up from one of the gentlemen who's an active youth, was telling us a story about being arrested when he went into the hospital with leg pain because he was in all this pain and he kept talking about it and they kept telling him, we're not giving you any kind of medication for pain. And he said, listen, if I want to get high, I'm going to use the heroin I have in my pocket. My leg hurts. I need somebody to help me with that. And they called the police and he was arrested. And he never got treated for his leg pain. So in these groups, people said, what if we just have little lockers at all the hospitals? People can lock, you know, just like at the train station, or lock away our stash and then give it back to us. Test it. Maybe you can test it and give it back to us. And all the clinicians went white, you know, and everybody's like, I don't know if we can do that. But from that came, what is our policy for somebody? This is their personal property. It might be illegal, but it's their personal policy. So what is our policy? And none of our hospitals had a policy of what to do when somebody had drugs on their person. And then, so that was a big change. And there were lots and lots of little tiny initiatives that happened from this. Conversation cards, so you can write down what you're taking, so you don't have to say it out loud. We're also rural, so there's only a curtain dividing me from my cousin, my mother, etc. But also better explanation, who are you going to tell? When do you have to tell my PO? When do you have to? My mom's out, you know, waiting for me. Do you have to tell her? But one of the things that I really found interesting was focusing. Whoops, that was supposed to be come later, but let's just go. I can just go with it. Is because that's how I do things. It's changing the measure of success. We have clinician burnout, right? This is in all our acute care. We have clinician staff burnout, and we have stigmatized patients because we're telling clinicians the only success that we're going to measure is how, if the patients that you see, are they still in recovery? Are they still in treatment 30 days later, 90 days later? Are they following up with the treatment recommendations that you gave? That's okay, I'm good. And as a mom who, my son is currently in very active use. And I have to tell you, I'm thrilled to hear the work on stimulants because for a long time he was not getting a lot of treatment. But I also had those as my measures of success. And that's burning people out. And it's telling people that they're failing. When our patients are saying, if I keep coming back, it's because you're doing something right. If I'm a revolving door, it's that I trust you. I got a tiny bit of something last time and I'm looking for something else. It might not be a recovery, but I'm looking for something else. And the staff is responsive. When I can go back to hospitals and say, this person, this specific staff person met people where they were and just got people named them, you know, that is a measure of success for our hospitals. Just something as simple as SUD screening. Like that, let's throw a pizza party for that if we get anywhere above 50%. And then just having discussions, right? This project, like people who were in recovery to start talking about it and start networking. So in hospitals that didn't have a peer program, they had started casual or informal peer programs for somebody who was in recovery on the staff would go to their patients. So thank you.
Thank you, Tanya. And again, appreciate the work and how, you know, engaging folks with experience, how it changes our design, how it changes how we do our work. Up next is Jason Pritchard, formerly of Ballard Health, now at Savita Health. And Jason led FORE-funded work during COVID to expand the number of peers and staff a warm line to support people with OUD. Jason?
Good afternoon, y'all. I figured I would get you ready for the Southern drawl here. So in 2019, I went to work for Ballard as a peer recovery specialist. I'm a person in long-term recovery. I spent 16 years in active addiction. In March of this year, I celebrated 11 years in recovery. I also celebrated in March 6 years post-incarceration. So I received a 6-year prison sentence, had to serve 5 years from March 20th of 2012 to March 20th of 2017. I came to work for Ballard, and we was looking at how to do reentry for people who had been justice involved and who were also looking for recovery. And so we created the Peer Help Program, and PEER is an acronym that stands for Programming, Education, Employment, Recovery, Help. And so we had started hiring peer recovery specialists who had justice-involved backgrounds, and our goal was to have them go into jails and prisons and navigate individuals to the social determinants of health, food, housing, clothing, things of that nature, but with the end result being sustained employment. And so we had a really good idea. We put pen to paper. We had a idea to get started, and then COVID hits and shuts everything down. So we come back to the drawing board, and we're like, how can we really keep the program going and move it forward with all of these regulations? And so we started out, we wanted to create a warm line. So our initial proposal to the FORE Foundation was for to create the Peer Help Warm Line, and we actually had the number worked out where it was 1-877 Peer Help, HLP. And we wanted to address SUD mental health co-occurring while aiding peers to obtain their 500 certification hours. So in Virginia, a peer has to have 500 hours of engagement in order to be certified. And we were going to let them be volunteers on the warm line to get their 500 hours. But what we were able to do, we got a grant, I think it was $75,000. We had decided that the warm lines would be stationed in all these community partners, and so we would be able to provide them a peer. The problem was that the COVID protocols started shutting down all of our community partners that we had identified. So we found out we can, instead of using a landline, we could use a mobile phone and still connect to the same software that we had paid for. And so then we had all these extra funds, and we were like, what are we going to do with all this money? So we started looking around at things we could do. So I'm getting a little bit ahead of myself. During the warm line from June of 2020 through May of 2022, we took 350 phone calls. They were 150 SUD related, 90 mental health related, 70 were social needs for themselves, and 40 were co-occurring needs with mental health and substance use. And then from the cost savings, we began to develop other peer things. And I actually had a conversation earlier. One of the things that we identified is that our peers needed ongoing training. So they needed workforce development. They had the basic skills to be a peer recovery specialist, but how do they become a community peer recovery specialist? So we started diversifying their experience. In the meantime, the Department of Behavioral Health Services for the state of Virginia created a virtual peer support training. So we got certified to be a trainer of trainers for that training, and we trained 100 individuals. 7 of those were incarcerated. We also added a Workforce Excellence Series in the IFIFRS, which is Integrated Forensic Peer Recovery. That teaches peers how to be engaged in the sequential intercept model within inside the Department of Justice. And we began to expand and teach the peers new things. We also instituted virtual in-person peer meetings. Those were covered by the FORE funds. We created 16 community recovery meetings. 10 were virtual, 6 were in person, and 4 of the virtual meetings were taking place in jails. We had our peers trained in SMART recovery, living free, faith-based recovery, moral recognition therapy, which is known as MRT, pathways to recovery, workforce excellence series, and bots and life skills. And we launched all of these, wherever we could do an in-person meeting, we did it. And if we couldn't do in-person, then we done virtual. And we use all of this to expand the workforce experience of the peers themselves.
Man, wind a hokey up. All right, there we go. There you go. Okay. Thanks, Jason. And up next is Thomas Gooch from My Father's Place, one of our new CBO grantees. And Thomas leads the project to expand connection to treatment services for men in Nashville. Please welcome Thomas.
I don't know why I feel like I'm in court. Is this the thing for the, because I don't really use slides. I'm telling you, I really don't use. Is that the slide? Is that my slide? Oh yeah, got my logo right there. Okay. Yeah, I don't really use slides, but I don't want to disappoint my best friend back there, SAMHSA, because I work with him. He works with my area medical college. The collaboration that I have with my father's house, Nashville, have with that FORE-funded was that we operate respite beds. And for anyone that don't know what a respite bed is, it's for an individual who's indigent, homeless, trying to get out of a desperate situation, trying to get into treatment. And as all of y'all probably know, treatment ain't a instant situation that can happen. You can't just walk into treatment and knock on the door and say, I want to get into treatment, and then they provide treatment for you right then and there. So for the individual who doesn't have no funding whatsoever, we FORE-funded us some money to provide a safe space for them to be at while a treatment bed is open. But even when they gave us this funding, we found there were some other things that we needed to provide for them that we weren't prepared for too. Some of them come without ID, some of them don't come with clothes, some don't come with the medication that they need to move forward. And I know, man, that Sarah and Brian can't wait for this to be over, because I've been blowing their emails up ever since they gave me this money. Every time I got an idea, I email them about it. I don't care what it is. I just keep on emailing them. And because my father's house is super excited for the funding that FORE gave us, because we provided some service that we couldn't have provided in Nashville had they not gave us this. Because the situation that we're faced with down there, we watch all the time when the individual go to treatment and try to get into treatment. When they made their mind up right then and there to get into treatment, but treatment can't get them in for whatever reason, go get 30 days of your medication. How many people can really go do that? They turn them away. Come back tomorrow because we don't take assessments on Tuesday. How many people gonna do that? What you think a person gonna do when they leave from there? The majority of them don't come back on the next day. So the services that we have started providing for them has been crucial to the existence of changing lives and saving lives, because that's what we are in, the saving life business. And I remember not too long ago, they sent me an email just a couple of days, because I wasn't even supposed to be doing this presentation today. I was on tomorrow's agenda, and it didn't even come with slides, and I was glad. You know, I emailed Sam. I said, "Oh, we ain't got to do no slides." And Sam, I'm like, "Well, good job." You know what I'm saying? And then they emailed me and said, "We got a change in plan, And before I responded to him, I looked at my phone for about 5 or 6 minutes, and I'm like, you can't tell them no. They just gave you $150,000. So I said, all right, I'll be delighted to do it. You know what I'm saying? And so I hit Sam back up and said, man, we got to create some slides, man, and get it to him. But I am very, very grateful. And then you just really don't know how God works, because the title of this panel is Those with Lived Experience. And when you use the word those with lived experience, this ain't just about, to me, ain't about the people who live through active addiction, although I haven't used drugs in over 20 years, but also my wife OD'd February the 10th, 2019, and I had an 8-year-old daughter and an 11-year-old son with her, so I've been a single father to them ever since she died. 2 years later, a mother of my other child died to this disease. So when it comes to this disease and the work that I do on a regular basis every single day, it's truly close to my heart. I also started the first syringe exchange program in Nashville, Tennessee in 2017, legal syringe exchange program, because there's been a whole lot of underground syringe exchange program. But I also went to Meharry and started a mobile syringe exchange program. So I'm in this process right here, 10 toes down. So I appreciate for what it is that y'all giving us, because y'all saving lives on a regular basis. When it comes to these numbers right here, I ain't even really into numbers. I don't even like to be checking boxes and all that, because I'm thinking about a human life. I'm thinking about how I can participate and engage with them and let them know life is different. It ain't, so, because when it comes to the numbers that we sent in to FORE, when we talked about what it is that we was going to do on our end for this grant, in 1 year, we said we'll get 60 people that was trying to get into Elam, get them to my father's house and get them engaged and try to keep them occupied until the bed become available. And out of those 60 people, we would get 30 of them into treatment. And that was in a year. It's only been 6 months. We 6 months into this grant, and we've got 34 people, and 27 of them have made it to treatment. So we already at that number in 6 months, you know what I'm saying? So we very well appreciate the funding that y'all gave us, and we will be big and for some more.
All right, so yeah, that speaks for Thomas speaks for himself. Let's go, man. This is I don't know what better punctuation on the day than hearing from this panel. So a few questions before we turn to Courtney for some closing remarks for this panel. And so one, I think, is any challenges that you've seen, engaging folks with lived experiences. What have been some challenges, and maybe some solutions off those challenges on, programmatically? We'll just open it up. Yeah, and please use the mics.
Well, we found that, especially looking to engage people who are currently using drugs, that we needed to go into the communities. We needed to find, we call them peer champions, who are part of the community. It was actually through a needle exchange program where she was going into different homes, into the community. So we did that. It was also having one person who is their contact person with the project, and then dropping all of my letters after my name, and not, really just making it a comfortable experience. We were in the first cohort, so we got our notification, as Karen had said earlier, in March of 2020. So we had to go completely virtual, and I actually think that was an asset. I don't know that we would have done that, that I would have done all of these focus groups and stuff, because I'm usually dependent on group dynamics, but that actually, I think, helped us have people be able to come, and we had them come and, while they were grocery shopping. And I mean, it was just we dropped all of the guidelines and etiquette of how to do a Zoom. It was early in Zoom land, so we didn't have any of those, but it was just trying to make it really comfortable, but really going into the community, being a part of it, talking about our own lived experience in it.
Is it on?
Yep.
So I think one thing that we encountered was the peers. I was sharing a little bit this before about like experience, like work experience, but also like experience with Microsoft Office. Some of them didn't even know what Microsoft Office was. And so one of the things that we did was we kind of created like a stackable credentials opportunity. So we looked at if the person came in as a peer recovery specialist, they could be cross-trained as a community health worker. They could be encouraged to go to the community college and get something. There was a CSAT, a certified substance abuse counselor's assistant. So that was a 1-year program. They could get that. Then they could get a 2-year human services, which could go to a 4-year human services. And in doing that, they were receiving professional development. So that was one thing. And then I want to share something that I read on LinkedIn this morning. It's by a guy, John F. Kelly. He's PhD. It says he's a professor of psychiatry. And he released this thing. He said, did you know the quality of life in recovery, it takes an average of 15 years for an individual in recovery to reach a similar quality of life as the general population. And so by the stigma and things associated with going through treatment with jobs that do not pay a living wage, like even when a person finds recovery, the process is still way uphill. So yeah, I just want to just add that.
I don't know, because I'm on something. I look at this from a different perspective. I've been doing harm reduction for quite some time. I've also was in Puerto Rico. We did the harm reduction conference was in Puerto Rico, and me and Sam was in a meeting that they had at the time, and it was talking about could harm reduction and recovery exist in the same place, and it can. I'm in recovery. I run transitional house for dads, for men, period. I run housing for men. I run the only men's house in Nashville, probably in the state of Tennessee, period, that's for dads. And not only that, we do not have the exact, not even close to the same resources that moms had. I just had a guy call me that had custody. In a divorce case, he had custody of a 6-year-old and an 8-year-old. Didn't have a place to go. He was in a domestic situation. The woman that he was with was abusing him and his kids. And this guy wasn't in Nashville, but he was in Tennessee. Had that have been a mom, she'd have had 1,000 places to go. But it was a dad, and they didn't have nowhere to send him when they reached out to me. So I'm in a place now that I'm trying to provide some services for dads because they play an important role in their kids' lives too. But we don't have those same type of resources. They don't even look at fathers and men the same when it comes to, it's a program in Tennessee that allow women to be in a program for 2 years while she get on her feet, while they take her through everything that she needs to know, and all the kind of training classes that she needs, but they won't provide those same services for men. So I'm trying to figure out how I can get those services for men, for dads, and for fathers, out of the home dads that's trying to create a home for them. So I look at it that way, and I look at it that even though I run transitional houses, even though I'm in recovery, harm reduction looks different to me because I'm in homeless encampment about 3 days a week, every week, pulling individuals out of homeless encampment who does not have a dime or no resources or no family, trying to figure out how they can get on their feet, and then how I can loop them in to resources to help them, because they all can't fit in to my father's house as well. So then where will I put them at? So I look at it different.
Yeah, hold on to that, Tom. So hold on. So right, you're doing this work, you're pulling folks up, you got people that are now, maybe helping you, right? And they're helping themselves, they're helping you, they're going along, and now they're working in the field. Now they're actually moving, coming up in the helping system, right? So I think everybody agrees in this room, we're all on the same page, that engaging folks with lived experience is really, really important. Not everybody agrees. And a lot of folks maybe still have stigmas and they're still, you know, holding on to old stereotypes and old ways of thinking, old ways of doing things. How do you work on that locally? How do you get people to see, wait a second, somebody in recovery, somebody with lived experience actually could do a great job doing this, this, and this? What do you do? What do you do locally to combat?
Well, for one, I've been super blessed, and a lot of people probably won't even get the opportunities to be able to do some of the things that I've done, to be able to go to some of the places that I've been, to even be on stages like this. This is a wonderful opportunity that Ford has presented to my father's house in Nashville, to Thomas, to me, period, for me to be here, because a lot of times we're not invited to the table. I was just sitting on the opiate abatement funding, which is $650 million. And when I looked at the table of the people who was at the table talking about that problem, I wasn't at that table. Wasn't nobody there to represent my wife who died at that table. Like the people who I know who need to be at that table wasn't at that table. Like, so sometimes our voice don't be heard. And sometimes it's a bittersweet thing, because if most times, man, when a person with lived experience sit at that table, they speak from lived experience. And sometimes it come off aggressive. You still got to be calm, even in that situation. You know what I'm saying? So just because you have lived experience doesn't mean you have all the answers. You know what I'm saying? So it's a bittersweet tug of war situation that goes on with that. But somebody with our voice has to be at the table for the opportunity anyway.
Yeah. Yep. I'll throw it open. Yeah. Tanya. Yeah.
I would say just live an example, and constantly looking for other people that have stories to show them how to be a champion, and advocating. I recently was able to do a breakfast with Governor Youngkin, and I spoke about, I'm a faith-based person, so I said, you know, I know God has pardoned me, maybe one day the state will. And so, and I was just being, you know, forward about it. It says you have not because you ask not, but that led to a huge conversation. And it's similar to what he's saying, take advantage of your platform. And so that actually led to, there's a person that's getting ready to take over the Office of Recovery Services for the state of Virginia who's never been granted a pardon either. They came to me, we went to the governor, and we've now both started the process. And it's teaching us how to start the process for other people.
Tanya?
Goodness. So one is, in terms of changing people's mind, I'm obviously a white woman and I have a whole lot of privilege. And when I enter into the healthcare system, not the treatment system, but when I enter with my son, I am not anything to most hospitals. And I have never been treated as poorly as I get treated, because in those settings, I am not Dr. Lord, I am not, I am only the mom who raised a drug addict. And I've never seen healthcare fail people as much as they have people who use drugs. So to me, I use that voice wherever I can. Sorry. This is what happens when you're with family. I'm like, you're all looking so simple. Most people are like, I'm not. We treat you just fine, because I'm usually talking to that audience. I have since this grant left and my Foundation for Healthy Communities, my other family, and I work for an organization where we don't touch. Every single proposal we put in has lived experience. It's not all substance use, but it's what attracted me to work there. I think it's talking about it, and it's challenging people on a one-by-one basis, that if any of your programs do not include people with lived experience, either on an advisory panel or at the table, or as an employee, and not just people who are 20 plus years or long-term recovery, but people who are experiencing, you know, these things, experience it now. I think I feel like it's a moral obligation of mine to challenge anybody. So I will challenge the federal agencies, and I will challenge people to do it. And I think, you know, like, we're good people, you know, and I think there was something, was it Lachey? Is that the video? When she says, I'm going to be a better person, she already was a better person. You're not a bad person because you use drugs. And I think that we need to start just, it's heartbreaking, right? Like you said, people come out of treatment, or they're using harm reduction, but they're functional, and it's just a mess out there. So I'm going to stop rambling.
Thank you, Tanya. Thank you. So now I'd actually I want to introduce Courtney and bring Courtney up to sort of tie up, you know, our panel and really around engaging folks with lived experience. Courtney is the director of training programs, the National Council for Mental Well-Being. She's a peer recovery coach, and she is thankfully also on the FORE Scientific Advisory Committee. So, Courtney.
Wow, what a panel. I'm probably a little biased, but this has been my favorite part of the day. You three are amazing. You're absolutely inspiring, and I'm happy I got to share space with you all. I didn't have slides. Karen said no slides, which, opposite of you, I need slides to keep me on track. So I'm going to try my best to be brief and concise today. As David shared, I work for the National Council, but I've been doing peer work for a long time now. A person with lived experience myself, in recovery for over 15 years. And I've been doing work in the macro level recovery space, leading into peer work for almost a decade now. And I have seen tremendous growth with peers. I've had the privilege of creating training curriculum, multiple training curriculum for peers, and training peers all around the country, as far as Vietnam and Russia and Canada. So I love all things peers, as you can see why. But we have a lot of work that we need to do. I have a question. How many people here are parents? Show of hands. A lot. Okay. How many of those who just raised your hands have more than one child? A lot. Okay. So for all of you who just raised your hands, can you relate to the difference in preparing for your first child to the efforts in preparing for your second child? Were there significant differences? Yeah, me too. I'm struck thinking of bringing my daughter into the world almost 13 years ago. I'm going to steal something from Dwayne from the conference this morning. Pray for me, please. I got almost a teenager, but I 3 years into my recovery process at the time, newly married and bringing a child into the world, I wanted to do everything right. Ever the overachiever. I, read all the forums, what to expect when expecting. I did all the things and found out that you don't necessarily do all the things correctly, even when you're trying your hardest to absolutely do everything correctly. For example, I did not know that you could not wait until the baby is born to try to get on daycare wait list. Yeah, you pretty much have to get on that daycare wait list the moment you find out you're expecting. So I got that one wrong, in spite of my efforts. And another thing that I didn't quite get right was the nursery, the crib. I put all my type A energy into making the most beautiful nursery and getting the crib just right, baby bumper on the outside, cute little fuzzy pink blankets, and the mobile and the stuffed animal, only to have a colleague of mine, public health worker, come over before my daughter was born and look at the crib and say, you can't do any of that, right? It looks cute, but that's not safe. You can't have the have the baby bumpers. You can't have the blankets. You can't have the stuffed animals in there. It needs to pretty much be a flat mattress, and they'll be better that way. So I put a lot of effort into doing it. I didn't quite get it all right. Fast forward to when my son was born a few years later, and I refined the process a bit. I made sure I got on that daycare wait list the moment I found out that I was expecting. I didn't waste even time with the crib and got the bassinet that was going to stay next to the bed for the first like 6 months anyway. And I think that that is pretty symbolic of where we're at right now when it comes to the greater SUD peer movement. We're like entering into our second child phase. We came in really zealous with peers. We wanted to put peers everywhere, and we did. We've got peers in emergency departments. We've got peers in jails. We've got peers in prisons, in clinical settings, in community-based settings. I mean, you name it, we've got peers, which is fantastic, and I fully support it. However, in our zealousness to bring peers everywhere, we missed a bunch of steps, and we may have put a lot of energy into some of the things that didn't need as much energy and overlooked some places that we should have focused more heavily on. And as the stewards or the parents of this SUD peer movement, I think it's our time now to take a pause, to take a beat, and to look honestly at the landscape of peers and what we have done and what we need to do in order to better protect this incredibly important field that is growing and will only continue to grow. I have a long list of suggestions and ideas that I could talk about, but I'm going to try to keep it to two. The peer workforce needs infrastructure, and we need to do better at protecting our peers. So those two things, if there's nothing else we take away from talking about peers, we need better peer workforce infrastructure, and we need to do so much better at protecting the peers doing this work. And what do I mean by that? Well, if you've looked at any of the qualitative or quantitative survey findings that FORE has put out over the past couple of years, you'll see a lot of what I'm going to say in those reports. And if you haven't looked at those reports, if you haven't looked at those surveys, here's your plug. Please go look at them. They're full of really great, important information, some of our first data that we've actually got around peers. So hopefully the first of many more initiatives like that. But what do we need? We need role clarity. So peers doing this work, they have a pretty good idea of what their role is, but the people that they work with don't know. Not just those who employ them, but oftentimes you'll see a peer employed by, let's say, a recovery community organization, but they're working in a jail or they're working in an outpatient clinic. Those roles interfacing with them on a regular basis do not have a solid understanding of the role of peers. We need to do better to train those individuals. As much as peers are trained, hopefully, to educate their colleagues on their role, it's not their sole responsibility to do their whole job and also to train everyone they interact with on what their role is. We have to do better with that. We also have to provide appropriate supervision. As somebody who is a former addictions counselor, I understand and value supervision in a clinical perspective, but I also see the difference between clinical supervision, let's say of a CSAT or an addiction counselor or a social worker, and the supervision that is needed for a peer worker. We have entirely different ethics. So if you're, say, a seasoned social worker who's been providing supervision to other social workers for 10, 20 years, and you just take that skill and think they'll apply universally to supervising peers, you're mistaken. They are entirely different ethics and issues that peer workers are dealing with. We need to make sure that those people who are providing supervision understand those ethics and they understand the situations that peers are faced with on a daily basis. Compensation. We need to make sure that we're compensating peers. Think of it this way. Peers often go into drug users' homes, into their recovery's homes. They have the thinnest boundaries of all of our clinical roles. They are the closest on a regular basis to death, to overdose, to witnessing. I mean, the number of peers that I know who have actually found their recoveries, the individuals they work with, overdosed, is incredibly different than from a traditional clinical perspective. We need to compensate them for the risks they're inherently taking because of their role, because of the different boundaries, because of the different ethics that they have to do their work. We need clear pathways towards a national certification, or at the very least, better reciprocity, so that those who are certified or credentialed in a certain state can do that work in other states. Think of social workers. You don't have to get credentialed in every single state or licensed in every single state to do your work. We should have the same for peers. We need ongoing training and education, professional development. I mean, aside from maybe a few hours for recertification, if there's even a certification process in the state, that's all that we have for peers. There's not ongoing training and education. So although peers definitely use their lived experience as the crux of what they do, there's also real tangible skills that peers use, motivational interviewing. There's real techniques that they could be further developing throughout their career, and we're not providing the opportunities to do that. And we need, I love this term, stackable credentials. We need a career ladder. We need pathways to move up. Peers are professionals just like the rest of us who have goals and aspirations, and we need to provide those pathways so that once we find and we train the best peer workers out there, that we can retain them, that they can become the supervisors, that they can become the leaders, that they can be sitting at the tables that we need to be sitting at, making these decisions. And we need to protect them. So what do I mean by protecting our peers? I mean, as I already explained, peers have very different ethics. And if there is a certification or a credentialing process in their state, they have to sign ethical agreements, just the same as any license or other credential or certification. When employers or places that are employing peers do not understand the peer role, they are often asking peers to do things that are against their ethical guidelines that they sign. So if you say you have peers and you're asking them to divulge at treatment court if their recovery has had a recurrence of use, or if you're using peers to collect urine drug screens, you're going against things that they may have signed to have their credential. And these asks are not only unfair, they're cruel, and they're risking the professional credential that individual has probably worked tirelessly to achieve. So we have to have better role clarity, better training so that individuals that we're working with understand these ethics, and avoid role creep that I see happen all the time with peers. When we don't have a full understanding of the role of peers, their ethics, what they're supposed to be doing, and we start to just put peers everywhere without training everyone who's interacting with them, peers start to be, at best, co-opted into a junior counselor role, and at worst, completely disregarded and asked to do things less than paraprofessional. And it happens far too often, but we can start to eliminate that role creep by having more clarity on the role and by also having further understanding of those ethical considerations. We need to train all the colleagues, everyone interfacing with peers on what the role is, and we need to provide support, ongoing support, because the work that peers are doing on a regular basis, like I said before, like we've heard illustrated already today in this panel, peers are dealing with individuals in active use. They're seeing overdose, they're seeing wounds, they're seeing some of the most severe situations on a regular basis and provided some of the least support of all the clinical roles. They have the most thin lines as far as boundaries between themselves and the individuals they're working with, and we're not providing them additional mental health counseling. We're not providing them additional resources, so they're burning out. They're burning out, and then it's just chalked up to recurrence of use or more stigmatizing language. Instead of taking a step back to realize the magnitude of the role that we are asking of these individuals without giving them additional support in order to be able to do that. So how can we do all this? I'm hoping FORE will just come up with a bunch of funding and give these people more money to come up with better solutions. But I think it starts with convening. We need to convene the peers doing this work, like a World Congress on peers. And as we've heard already at this panel, we need to be at those tables, not just at those tables, but building the tables with the solutions, not just in a tokenized manner, but really coming up with the answers. We need an association, just like social workers, just like AAP, just like every other professional role, we need somebody to defend the rights of peers, and that doesn't yet exist on a big enough scale. But we should get there. And we need to develop true models of where we see peers being integrated properly and strongly into all sorts of settings. We need to lift up those models. We need to make them accessible for other organizations so that when we're implementing these peers in this baby fever of the peer movement that we're in, we're doing it correctly. Because just as new parents, when we're bringing in our bundle of joy into the world, that does not mean our work is done. It has only just begun. So now is when we start to do the real work to make sure this is a sustainable, long-term solution to the crisis. Thank you.
All right, so I think this launches us into the next tomorrow for the grantees. It's a great way to end the day with this kind of energy, with this kind of, I think, insight. And so as we close this panel, I would just ask you to thank the panel for their insights and all their help. Thank you all very much. Thank you. And now we'll bring up Dr. Scott.
Thanks so much, David. That was a terrific panel. You were right, Tanya. We saved the best for last here. Amazing. Thank you all so much. Just a couple of announcements and a couple of closing remarks from me. On the announcement side, my team wanted everyone to know that they were able to find locations to donate food that was left over from lunch. So nothing is going to waste. Always working. That was an amazing initiative, and they were able to donate the food to a church just across the street. So that will all get put to good use. Also, just in terms of announcements, for our 4 grantees, we will be back here tomorrow, but we do need you to take all your personal belongings with you today so that we leave the room empty, as well as kindly for everyone, if you've got any trash, just throw that out on your way out. We do invite everybody to join us back at the Capitol Hilton starting at 5:30 for our reception to celebrate our 5th anniversary. An opportunity to really to spend a little bit more time together, take a breath, and enjoy the evening. So I hope that we'll see you all back at the Hilton in a couple of hours or less. Finally, I just want to make a couple of takeaways. There's obviously a huge amount from this day for myself, for my staff, for the board to be thinking about, and as we continue to think about planning our next few years. So I just have a couple of just very broad, high-level things that I will take away from today. And the first, without question, is just watching how much networking and conversations and people sitting at tables on the side and in the corners. There is nothing like really bringing people together in person, and it's so great that we're able to do that again, and that you all made the trips and are doing that with us today. So thank you for coming, for making the trips and the times. It is really wonderful to just observe all of those interactions, and I know that that's going to lead to even more ideas and even more great work in the future. We regularly say in the office that we have amazing grantees. Whenever we're doing a webinar, I'm like, I'm not worried as long as we've got our panel of grantees coming. And you saw that. Everyone got to see a little bit of that today. So once again, thank you, particularly to our amazing grantees. Our first cohort that started in March of 2020 found ways to keep that work going in the midst of everything else that they were managing and doing, including in the emergency departments, including on the front lines of COVID. And it was incredible to watch the innovation that came out of trying to figure out how to keep that work going. And then finally, I'm leaving really energized We've had incredible discussions. There are clearly opportunities and lots of great ideas for how we build on the work that we've supported over the last 4 or 5 years. Lots of people to connect with and ways to think about how we spread, how we take some of these ideas and the conversations from today across access to treatment, doing more work in the communities, engaging more people with lived experience as we think about how we move forward and hopefully engage, again, more and more organizations, more foundations, as well as public agencies in this work. So thank you for helping to bring that energy into today and into discussions I know we'll be having going forward. Again, I thank my board, I thank my team for keeping everything running so well today and all the work in leading up today. And I hope I'll see you all around 5:30 at the Hilton. Thank you. Okay.